I would like to express my deepest gratitude for your kind personalities attending this conference. This conference entitled Health Sector Challenges and Anticipations, aiming at discussing the challenges and the future anticipations of health sector in Gaza Strip to coordinate the efforts towards meeting the goals of the health sector in Gaza Strip that has been under blockade for 15 years.
ما فيش صوت
We, the Palestinian Minister of Health, would like to assure
إنه
you.
صوت
الصوت مش واضح.
حتى السماعة رفعت السماعة.
Is it unclear? Is it unclear?
لقد جنينا عليك يا هذا.
كيف حالك؟
طيب ايش فايت؟ طيب انت بس بدك تسمع بدكش ايش تمام؟
Okay, let's continue. Actually, we and the Palestinian Minister of Health would like to assure you that your support has been directed towards people who suffer not only for wars and the Great March of Return, but also the consequences of the worldwide COVID-19 pandemic on 2 million populations who live in poverty and pain. The last Israeli aggression put the healthcare system on the verge of collapse. With every Israeli aggression, violations to the international laws are being committed. Israeli aggression forces have deliberately been targeting health facilities, including hospitals, primary health care, doctors, paramedics, ambulances, and the main roads leading to the hospitals, delaying the accessibility of patients and wounded to health services. In the last Israeli aggression, the Israeli airstrikes killed Dr. Ayman Abu al-Auf, may be rest in peace. He was the head of an internal medicine department in Al-Shifa Hospital, leading the battle against COVID-19 in Gaza Strip. The death toll of the last aggression has risen to 257, including 66 children, 39 women, and 17 elderly. The injured have reached 1,948, including 277 children and 412 women. The Israeli aggression was coincident with an ongoing closure of Beit Hanun crossing, denying the accessibility of patients for treatment in the West Bank and Jerusalem. There have been Israeli claims of allowing critical cases, but despite that, they refused to respond to dozens of permit requests applied by Health Ministry Coordination and Liaison Department on behalf of patients with serious diseases, whose treatment is not available at Gaza hospitals. Between the 25th and 30th of May, 139 patients out of 151 were denied access to their treatment, to succumb to their destiny from treatable complications. And let me commemorate all those who passed away while awaiting their travel permission, including Hassan Ahmad Abed, who had tongue and throat cancer and died on Sunday, on the 30th of May 2021. According to records of Palestinian Ministry of Health, hospitals and medical centers in Gaza Strip currently suffer from serious shortage of 45% of the essential drug list and 33% of medical consumables and 56% of the laboratory products and blood banking supplies. Healthcare personnel are working with only 50% of their salaries. Today, we have thousands of patients who are expecting the Ministry of Health to continue treating them. For instance, there are 1,000 patients with renal failure and in need for dialysis, and almost around 9,000 cancer patients are waiting for their treatment permission across the Beit Hanun checkpoint. The Israeli drone threats are still existing in our sky. The blockade is tightened, and the problem of medication shortage is not yet solved. All thanks to the medical staff who dedicated their efforts to help and protect their people, even in this means to put their lives at risk. The Palestinian Minister of Health in Gaza highly appreciate your presence here today. Your effort to stand with the healthcare system, supporting it, trying to rebuild its capacity and strengthen those difficulties and strengthen in those difficult times to enhance our preparedness and readiness. Really, I would like to appreciate your presence today and esteemed respect for all of you. Thank you. شكرا عندك يا أم سالم.
Thank you, Dr. Youssef, for your opening speech. Thank you also to all our partners and colleagues once again for participation. And now is the floor to Dr. Abdulatif Al-Haj, the Director General of International Cooperation in the Ministry of Health, for opening remarks. Please.
Assalamu alaikum.
Assalamu alaikum.
Bot unmute, Dr. Abdul Latif. Bot unmute.
Assalamu alaikum. Assalamu alaikum. I would like to
إذا في عندك أكثر من مايك سكرهم كلهم وخلي واحد بس يا أبو المجد.
السلام عليكم. Okay, thank you very much.
It's okay now.
Yes, yes. Good afternoon, all of our partners who are sharing with us this conference of the Minister of Health. That the Minister of Health will summarize the needs, because our needs, our problems are too much detailed, and we try to make themes, 5 themes in this conference, that each theme is concentrating on one of the main items of the components of the services that we are providing in Gaza Strip, either the governmental sector or with the non-governmental sector. Now we will start our speak by the International Cooperation Department presentation to summarize the situation in the health status in Gaza, the update in the situation that will highlight the updates in the health determinants, the reflection of the health determinants of the situation in the health services provided by the whole components of the health sector in Gaza, the reflection of the blockade on the very long blockade since 15 years on our health sector, the problems of the resources, either the human resources, the medications, the consumables, the problem of the services that are suffering a lot, and the vulnerable services, mainly for the vulnerable groups like the oncology, the effects of the closure, the long period of the siege on Gaza Strip. Let's start with our presentation. Please, Oksana, start with the presentation. Thank you very much.
Okay, thank you. Thank you, Dr. Abdulatif. So, as indicated in the program of the conference, we have first presentation on the health status, and then we have 5 sessions. Each session is devoted to each particular service. Each session will be headed or led by a facilitator, being a representative of one of our partners organizations. Let's start with the presentation on the health status. I will not go into details, we will focus on the general context in the Gaza Strip, giving particular attention to the some demographic issues, to social determinants of health. Then we will focus on some selected health indicators, and the last few slides on the challenges and anticipations. Oh, okay. The first, this is the, as I said, I will not go into the details, just to remind that the Gaza Strip is one of the most densely populated areas, where more than 2 million people residing on the area of 365 square kilometers. The Palestinian population in the Gaza Strip is a young population, where more than 1/3 of the population is young. About 41.2% of the population are less than are under 15. Now, regarding the social determinants of health, it is also was mentioned in many reports that the unemployment rate in the Gaza Strip is high. According to the PCBS statistics of the fourth quarter of 2020, the unemployment rate is 43.1%. Sorry, just we are following the slides, and regarding the poverty rate, also it was mentioned that the poverty rate is also high, and deep poverty especially. About 80% of the Gaza Strip population depend on the one kind of humanitarian aid. The water supply, we face very serious problems with the water supply to the population of the Gaza Strip. It is the water pollution is more than 90%. Almost 33 million cubic meters of the untreated sewage is dumped into the Mediterranean Sea per year. And the water deficit is 110 million cubic meters per year out of the 200 million needed. Only 10% of the water wells in the Gaza Strip comply with the WHO standards. Just a moment, please. The power supply for many years, the Gaza Strip has been facing the power supplies was a persisting problem, where the power outage reaches from 6 to 12 and sometimes to 16 hours. According to the OCHA latest statistics, the power deficit stands at about 50%. Next, please. Regarding the healthcare providers, as we all know, the main healthcare providers in the Gaza Strip, the Ministry of Health, UNRWA, local NGOs, military medical services, and private sector. Next, please. Primary healthcare services mostly provided by the MOH and UNRWA, though also NGOs have quite a good share in providing these services to the population, in addition to the military medical services. As for the secondary healthcare services, Ministry of Health covers about 90% of the population needs in this level of services. According to the latest statistics of the Ministry of Health, during 2020, there were more than 200,000 admissions to the hospitals, with 76.7% of these admissions being in the Ministry of Health hospitals. The Gaza Strip health sector also has very high bed occupancy rate, especially in the governmental sector, in governmental hospitals, where the occupancy rate is 78%, with Shifa being more than 100% occupancy rate. Just the next information or figure witnesses or that the burden on the governmental sector hospitals where surgical interventions performed during 2020 were about 100,000, with 63% of them in the Ministry of Health hospitals. Well, about the selected health indicators, just I will say about some of the most important ones. During the discussion sessions, more information can be provided. Maternal mortality rate stands at 24.2 per 100,000 live births in 2020. These indicators are for the 2020, as it is mentioned in this slide. The prevalence of anemia is still high among pregnant women, 40.5. About 63.2 of total deliveries were at the Ministry of Health hospitals. Infant mortality rate stands at 10.7 per 1,000 live births. Neonatal mortality rate stands at 6.8 per 1,000 live births. 10.7% of children under 5 suffer from chronic malnutrition. This is according to PCAPS 2019. Prevalence of anemia among children is also very high, being recorded at 70.2%. Next, please. Next slide, please. Okay. Regarding the non-communicable diseases, the prevalence of diabetes mellitus 3.1 per 100. Hypertension prevalence rate 4.7 per 100. Crude cancer incidence rate, the latest statistics that we have is for 2018, 90 per 100,000. Among all tumors, breast cancer stands at 17.9%, and among females, it is ranked at the first, standing at 32.8%. The mental illness, the incidence of mental illnesses among males was registered at 58.4%, and among females, 41.6%. This is according to the report of the MOH 2019. Next, please. The health sector, the operation theaters, the number of operation theaters in the health sector, the total number. Can you please just go back to the operation theaters? Next. Next slide, please. Okay, 97 operation theaters, out of which 49 at the Ministry of Health, 36 in the NGOs, and 5.3 in the hospitals run by military medical services, and 3.2 in private sector. Regarding ICUs, the total number of ICUs, general ICUs, is 161, with 150 in the Ministry of Health hospitals, 7 NGOs, and 4 private. Another concern is patients with renal failure, the number of whom is 938. For the services, hemodialysis services, we have 1 renal dialysis unit per 7 patients, where globally the standard is 1 renal dialysis unit per every 4 patients. Next, please. As mentioned by Dr. Yusuf Aburish, we are still confronting the COVID pandemic. And since the onset of the pandemic in the community in the Gaza Strip, more than 100,000 cases, positive cases were registered in the Gaza Strip, with where the fatality reached 1,040 cases. Currently, a total number of 75 patients undertaking or undergoing medical care in the MOH hospitals, with 58 care patients being in severe and critical status. Next, please. Vaccination. The Gaza Ministry of Health has received more than 200,000 doses of vaccines. Until now, fully vaccinated people reached 36,000, more than 36,000. And according to the recent directives, the staff working in the Ministry of Health, Ministry of Education, and Ministry of Interiors has to have vaccination on a compulsory basis. Next, please. Challenges where the Ministry of Health and the health sector in general has been facing for more than a decade, multiple challenges and protracted crisis, which one of them we can just, I would like to focus on resources. Among the resources, the health commodities, which are the drugs, medical disposables, and lab supplies. Can you go back to the previous slide? Regarding drugs and medical disposables, recently the zero stock was staying at 40% zero stock or lack of supplies for quite a period, but in terms of cost, you can see that the gap between what is available and what is needed is 40%. For medical disposables, this lack, I mean, in terms of cost, is 36%. Among other health commodities, the Ministry of Health is facing difficulties and challenges in securing the needed medical equipment, especially the sophisticated one, as well as spare parts for the maintenance of this equipment. Next, please. Human resources. Human resources is one of the most important challenges that the Ministry of Health has been facing, as in terms of understaffing. We lack health specialists, especially highly qualified medical staff. We lack training opportunities to upskill our staff in order to provide quality health care to the population, as well as it was mentioned previously, salaries. The health staff in the Ministry of Health, which accounts at more than 11,000 employees, has been receiving for quite a long period salaries at the level ranging from 50 to 70. I mean, for employees employed by Gaza and the employees of Palestinian National Authority. Poor infrastructure in some health settings, and I think it is reflected in the high bed occupancy rate. Access to healthcare, lack of specialized services, especially the advanced one like radiotherapy, renal transplantation, oncology surgery, and as a result, referrals for treatment abroad and sufferings that our patients face seeking the treatment they need in terms of permit denials, interrogations, and as well as the high financial burden on the health system itself. Next, please. The last escalation of hostilities on the Gaza Strip has resulted in damages in health facilities where 10 hospitals were partially damaged, 22 primary health care centers also partially damaged, and 1 primary health care in the northern governorate was fully damaged. During this escalation and unceased airstrikes, Israeli airstrikes, almost 2,000 civil people or civilians were injured, among whom were over 600 children and 400 women, some of whom may still need long-term rehabilitation. Next, please. Anticipations. So as it was mentioned, we hope that together through a concerted and consolidated efforts, we can achieve at least some of these expectations, which are linking humanitarian aid and development programs, advocating for lifting the siege, ensuring continuity of essential healthcare delivery, providing training opportunities for the health staff, advocating for full salaries payment for the health staff, strengthening partnership with various local healthcare providers, enhancing partnerships with international NGOs, and donors' support to the health sector. Okay, thank you for your attention, and now we will watch a short video about the status in the Gaza Strip, the health status in the Gaza Strip. Okay.
هي رحلة العذاب تتعاقب فصولها بأوجه شاحبة أنهكها طول الحصار، وصدعت معها عيون المرضى ترتقب لحظات أخرى من الألم، فلم تعد حياتهم قادرة على الاستمرار. فغزة اليوم ضاقت بما تحمله من أزمات معقدة تلتف بخناقها على رقاب المئات من المرضى.
تعبت من نفس اليوم في الليل، بابا ودانا على المستشفى، فلقوا عندي وظائف الكلى عالية، وعملوا تحاليل لقوا في فشل كلوي معايا، والحمد لله من يومها يعني لقيت، وانا يعني تقريبا 6 سنين صار لي وانا بغسل 3 مرات كل اسبوع، تعب ومعاناة.
ولعل في حياتهم المذبوحة ما تبقى من خفقات تنذر بما هو أصعب، فالواقع المعيشي والاجتماعي والاقتصادي ليس بأفضل حال من وضعهم الصحي، ليجدوا أنفسهم أمام حالة أشد قتامة أتت على كل فرصة لاستكمال رحلة علاج طال انتظارها.
بسبب الحصار على غزة، وكمان يعني العلاج بنقطع، يعني بنقطع أكثر من بيتوفر العلاج، نصير نضطر نشتري على حسابنا. صار معي شاشة عظام، نقص كالسيوم وصل إلى أدى إلى شاشة عظام، بطلت أمشي.
أنا مريضة بالميلومة ومريضة بفشل الكلى وعندي مشكلة في الصمام، وأنا لازم أخذ علاج في كيماوي، بيطلعوني على الضفة مرفوضة أمنيا، ببعتوا لي إنه كنت تحت البحث، للآن ما رحتش. بناشد العالم كله وأصحاب الضمير الحر إنهم يساعدونا.
والكثير هنا من مرضى غزة أنساهم المرض تعداد سنوات الحصار، فيكون صمتهم بالرغم من شدة أوجاعهم هي البلاغة في التوصيف. وأمام تلك التحولات المخيفة انطلقت مسيرات العودة وكسر الحصار في 30 من مارس العام 2018، رفضا للحصار الذي داهم أبسط الحقوق الحياتية لمليوني إنسان. إن الاستخدام المفرط للأسلحة الفتاكة من قبل الاحتلال أدى إلى الآلاف من الجرحى ومئات الشهداء، ليضاف إلى سلسلة الاعتداءات الإسرائيلية التي شهدها القطاع. ولم تكن تلك الفترة العبء الكبير، فقد وقف قطاع غزة أمام تحد جديد ومن نوع مختلف، تطلب من الاستعداد والجهوزية ما يمكن منع حدوث كارثة صحية وإنسانية في أكثر منطقة جغرافية ازدحاما في العالم. فكيف لنظام صحي ضرب الحصار عصب مقوماته ومقدراته أن يواجه تداعيات جائحة كورونا؟ لقد مثلت تلك الأحداث تحديا حقيقيا وكبيرا أمام وزارة الصحة في استمرار تقديم الخدمات الصحية، مع استمرار تفاقم نقص الأدوية والاحتياجات الطبية، وارتفاع نسبة إشغال الأسرة المخصصة للرعاية الطبية، مع تسجيل أعداد كبيرة من الإصابات بفيروس كورونا. وما إن بدأت وزارة الصحة من الخروج من تداعيات الموجة الثانية لفيروس كورونا، حتى باغتت طائرة الاحتلال الأحياء السكنية في قطاع غزة والمنشآت الصحية منتصف مايو من العام الجاري، لتجد المنظومة الصحية المنهكة أمام مهمة أخرى. فبين علاج الجرحى ومتابعة مصابي كورونا واستمرار الخدمات الصحية بشكلها الاعتيادي، يصعب التخيل كيف كانت التفاصيل وقسوتها. وأمام هذا الواقع الصعب وصرخات تخبو حدتها، تنتظر من يكتب نهاية لمأساة المرضى قبل أن يضع لهم الحصار حدا لحياتهم.
Okay, thank you for this video. Now we will move forward with, according to our program. We are having the first session now devoted to the emergency care services and including operation theaters. I am pleased to present Dr. Abdelnasser Sabah, who will be the head of the session. He is representing World Health Organization, one of the main partners of the Ministry of Health. Dr. Abdelnasser has an extensive experience working in the health sector, working for 14 years as a regional director of nursing in the Kingdom of Saudi Arabia, then working as a ward manager in Croydon University Hospital in London for 7 years. And since then till now, he is working with the WHO as the health cluster coordinator. So Dr. Abdelnasser, the floor is yours.
Thank you, Ksenia. And once again, good afternoon, ladies and gentlemen. And I want also to thank you for attending and participating in this conference titled The Gaza Strip Health Sector Challenges and Anticipations. The first session, or in this first session, we will, our presenters will explain the health service delivery for emergency cases, trauma or non-trauma, going through the process of the process from the field to the hospital, including the safe transport to emergency department, and then the care received in the emergency departments, and conclude the session with the capacity and care in ICU and operation theaters. Each presentation will be 10 minutes, And at the end of the 3 presentations, we will have 15 minutes for questions and answers. And we will start with a presentation on pre-hospital emergency care, which will be conducted by Mr. Ashraf Halewa, who's the Director of Emergency Medical Services at the Ministry of Health. And personally, I know Mr. Halewa, who has a very good knowledge and extensive and long experience in emergency medical services. He witnessed all military conflicts or wars since the year 2000 to date. So he knows even the history of how emergency medical services are conducted, including the challenges. Without any further delay, I would like to invite Mr. Halewa to start his presentation for 10 minutes, please. So, Mr. Ashraf, please, if you can start.
Yeah, thank you. Assalamu alaikum and welcome everybody. I am very honored to be with you today as a speaker on behalf of the EMS, the hospital EMS. As we know that the pre-hospital EMS is a part of the continuum of the NCHS. I'm wondering if you are English.
We can hear you. We can hear you, Ashraf. Go ahead.
So, welcome everybody. You know, and about the healthcare sectors, EMS represent about the first chain in this continuum is the community. So the emergency healthcare service, and then the emergency.
We cannot hear you, Ashraf. If you improve the voice quality, the sound quality, please.
Okay, so we had a committee for care services.
Sorry for interruption. عبد الناصر استبدل اخونا اشرف باي احد اخر، واشرف يتحرك تعال على الوزاره بحيث النت الكويس.
Okay, if Ashraf, till you solve the problem, maybe we can move to the next presentation. Although the presentations were aligned to go through the pathway of the case, which is pre-hospital, then at the hospital, and then we move to the ICU. We'll return back to the pre-hospital with Ashraf. Maybe we can move now to the hospital care, which starts from emergency department, and our speaker will be.
I can start.
Are you okay now, Ashraf?
I can start. Yeah, I think yes. I am okay. I'm okay now. Next please, next slide.
All right.
Yeah, okay, we are talking now, we'll review together. Yes, we'll review together the essential information regarding, so we have, we'll talk about the healthcare service, emergency healthcare service in Gaza Strip, and then we'll talk about the current gaps, priorities, and summary of the projects.
دكتور عبد الناصر، أرى أن الموضوع ليس اوبشنال لأخونا أشرف. جو تو نيكست. هو أشرف يتحرك من مكانه، هذا الموضوع مش اوبشنال، يعني خلص توكل على الله. جو.
Right. Ladies and gentlemen, sorry for this bad quality of the sound from the side of Ashraf, but as I said, we might move to the next presentation, and it will be at the hospital phase where the case will reach.
I changed my position now and I can continue as the technical.
أشرف معلش، الآن حنروح على البرزنتيشن اللي بعده وأنت تحرك من عندك، الله يرضى عليك.
Okay, Dr. Thank you.
So again, as I said, we will move to the next presentation, and our speaker will be Dr. Muhammad Al-Attar, who will present to us, as I said, the hospital department. Dr. Al-Attar is the head of emergency medicine unit at the General Administration of Hospitals, and also Dr. Attar has a very long experience in emergency medicine. He's holding a Palestinian board in emergency medicine and also diploma of higher education in disaster medicine. He's known as an instructor also in many emergency courses and programs. Dr. Attar, if I may invite you, please, and if I can remind you, we have only 10 minutes for the presentation. Floor is yours, Dr. Attar.
بسم الله. الصوت كويس بيقعد اشرح وخلي حضرتك بعد كده
Good afternoon. I'm Dr. Muhammad Al-Attar. I am head of emergency medicine unit in General Administration of Hospitals. I will speak about needs and what we are planning to do, or what we planning to publish regarding the needs of emergency departments in our hospitals. Four items. I will speak about, a little bit about the overview of the situation in the emergency departments. and current gaps under the priority and summary. The Gaza Strip has been in a state of continuous emergency over the past year. This state, unfortunately, expected to continue due to conditions are going through recurrent crises, including the ongoing until now the coronavirus outbreak. This unusual situation exhausted the emergency departments and carried a great burden in view of these circumstances. This crisis crisis in emergency department requires strengthening and raising the readiness to deal with current and future different scenarios of emergencies. Emergency department in Gaza Strip provides services to about more than 2 million people. During just the past year, the emergency department received and treated more than 1 million persons. This huge number reflects the great burden in the emergency department, which require continuous support. What are our gaps in emergency department services? First thing, the policies, procedures, and protocols. As many of us know, that the emergency departments operate basically without unified national policies and protocols. This year, a special program was defined by General Administration Hospitals in its operational plan to establish and develop and update the national and treatment protocol. Regarding the staff training, the gaps in staff training, staffing a new medical personnel, especially doctors, junior doctors that the Minister of Health directed to the emergency department especially, and nurses, patient services. This all stuff need to enhance and making different programs, training programs to increase their ability to deal with the service emergency department. Regarding the equipment, the gaps in the equipment, there is a shortage over time in equipment and tools in the emergency departments as a result of the continuing crisis and in the health sector and a result of recurrent major incidents, thus justifying to support the emergency department with the equipment needed to be prepared for different emergency scenarios. This, the same thing we can talk about the drugs and consumables. Infrastructure. Most of our emergency departments in Ministry of Health hospitals are old and were built under abnormal and non-standard fashion. Most of them are tight and structurally disorganized. Some of them need to be redesigned and expanded to meet the routine emergency and major incidents. The 6 gaps that we need to focus on: the disaster or emergency management. There is no unified disaster management training program in the Ministry of Health until now. This requires establishing and developing a training program that can help emergency health workers to be prepared to deal professionally with the different disasters and crises. We put 10 big programs, emergency programs, to enhance and to strengthen the emergency department services. But in this year, we will focus just in some of them, just 5 programs. First program, first project that we need to work on the improving the resources and drugs and supplies for the emergency department. As we mentioned, because the different and continuous emergency that emergency departments facing, this justifying to put this project in the top of the priority. We need to ensure that the emergency departments has their resources to give or to give their services appropriately. We want to focus in same hospitals which has emergency department receiving general or trauma patient. This hospitals or emergency department in Al Najjar Hospital, Nasser Hospital, European, Al Aqsa, Al Shifa, Indonesian, and Vietnam. Second project that we need to work on, the capacity building or the okay. Second project that we need to work on the capacity building of emergency department workers. We mean here doctors, nurses, and patient services staff. This the second project that we want to work. We will target our doctors, junior doctors that the Minister of Health directed to emergency department. We talk about 100 doctors, new doctors, and other and nurses and staff and service staff, patient service staff. Third project that we need to work on improving the work environment in emergency department. That means we need to make some minor infrastructure renovation. As I mentioned before, most of our emergency departments are designed and built in past year for long time, and they need to make some renovation to make the service easy for the patient and for the staff. Fourth project, improving the work environment in emergency department. We are talking about other things that can enhance and improve the emergency department work. That means we need to employ or to make something regarding the security and patient services. Without good security and without security services and patient services, I think all our efforts regarding to enhance or to improve the work in emergency department will be limited and not appropriate. So this project talking about the ability to support, to supply emergency department by security and patient services to improve the care provided in emergency department. Fifth program, establishing or developing procedures, protocols, and the policies. As many of us know that there is some policies and procedures that done before. Maybe these procedures need to be to update or to make some review and to make some other protocols and increasing the protocols that already were done. This project need to focus on, and I think we can in this year focus in the trauma protocol, especially, and to complete these protocols, and then we can go for other protocols. Sixth project that we need to work on, the building local capacity to respond to mass casualty in Gaza. As many of us know, no evidence-based response approach to mass casualty in Ministry of Health until now. No unified approved training program available in Ministry of Health. Emergency worker request for training to mass casualty. We received many requests and ask from our colleagues from who are working in emergency department, they need to improve their ability to deal with mass casualty. So they need a good program and mass casualty program that can improve their ability to deal with mass casualty and emergency and major incidents. Shortly, this is the 6 programs or projects that we need to focus in this year. In summary, first one, providing emergency resources. Second, capacity building for workers in emergency department. Third, improving the work environment in emergency department. That means we need to make some renovation and minor infrastructure changes. Fourth, in this field, we need to enhance or support emergency department by security and patient services. Next one, establishing or updating or renewing the policies, procedures, and treatment that related to emergency department work, and building local capacity to respond to mass casualty. Thank you very much.
Thank you, Dr. Attar, for this comprehensive presentation. We will go back with the presentation, the first one, because of the problem that we have encountered. So once again, we want to hear from Mr. Halewa about the pre-hospital. But maybe while Mr. Halewa is preparing himself, I want to sum quickly Dr. Attar's presentation for the emergency departments, where he explained that about 2 million persons may be visiting the emergency departments at the Ministry of Health. He spoke about the gaps, including the unified national policies and procedures, staffing and health worker problems, the shortages of equipment, drugs and disposables, the infrastructure, the design was improvised rather than a suit for emergency care, and then the disaster management training and capacity. I think Dr. Attar has summed for those donors or those partners who would wish to help the Ministry of Health. He has identified 7 areas that they may invest in, and he spoke about the 7 hospitals with emergency departments that need to invest in their capacity, building of health workers, for about 100 doctors and nurses, the infrastructure renovation or rehabilitation to improve the services, to improve the working environment that includes the security, patient affairs services, maybe privacy, safety, and all of these issues, and then the development of policies and procedures manuals unified for all MOH emergency departments. And then he spoke about the building the local capacity for mass casualty management. And finally, the resources, including the lab, medicine, consumables, and all those needed at the emergency department level. With that, we will go for back again to Mr. Ashraf, please. If you can go for the pre-hospital level, floor is yours, Mr. Halewa.
Yeah, I'm waiting just for putting the presentation.
Are you there, Ashraf?
Yes, I am there. Yeah, Dr. Nasser. Okay. We are going to talk about the yeah, Dr. Nasser. I'm ready. So I'm ready. We are going to talk about the EMS, the hospital EMS. We have talked about the High Committee, which represents all the healthcare providers, including the main four providers, MOH, BLCS, Civil Defense, MMS, and the NGOs. We'll talk about overview about the healthcare services, emergency healthcare services. We will talk about current gaps, priorities, and summary. In this graphics, it shows the distribution of MOH ambulance vehicles and centers all over the Gaza Strip, the 5 governorates. We have 71 ambulance vehicles. 21 of them is ICU, and the rest of these vehicles is a basic ambulance. We have 1 repeaters, we have 1 tower, we have 54 handset, and we have a vehicle mounting about 40 units, and this is not enough. Here we are talking about our ambulance vehicles. As you know, it's about 85% of these vehicles is worn out, depreciated, old model, old fashioned. They donated since the war, 2008. Also, these vehicles it's not fulfilling the minimum standard for international standard for as an ambulance vehicles. Also, here we are talking about the fuel. About 69% of these vehicles is diesel, which is come with our emergency plan, because the diesel we can make as a strategic reserve. We can make the strategic fuel reserve. Here we are talking about the ambulance vehicles and the staff, number of staff and number of centers for all healthcare providers. Unfortunately, if we are talking about the ambulance vehicles, comparing with the international standards of the regional countries, we will find that it is fair enough, the number of the ambulance vehicles. But if we are talking about specifications and we are talking about the equipping of these ambulance, it is not fair and it is not enough, and it's not meeting the minimum standard. Also, these vehicles, the same for other healthcare providers. I mean, the BRCS, the Civil Defense, and other providers, they have the same, facing the same problems regarding the ambulance vehicles. As you know, the demands increase and the workload overwhelming the ambulance services. We are talking about wartime, and we are talking about the pandemics of COVID. We face many problems regarding the load of the war. So these vehicles become old-fashioned and depreciated, and this is very clear. Here we are talking about the High Committee and the rules of each healthcare providers. In the High Committee, they distribute and they mandate the pre-hospital services and distribute the pre-hospital services according to each specialty. In this graphics, we are talking about the past year statistics. It shows the mission, the load of the work, and also it talks about the COVID cases, and it shows how much the number is huge and how the overwhelming of the MOH ambulance services with these work missions and workload. I tend to put this statistics for the 11th day of the last war, just to show that we share, we are not only working for our mandate as between hospital and in-hospital services and to the borders, but also we share the PRCS work in the field. This is made overload also for our ambulance services. Also put our crew at risk because the PRCS, I mean the ICRC, the international committees, they did not fulfill their commitment toward the protection of our. If we are talking about the current gaps in the ambulance vehicles, it is, as we said, it is old-fashioned, depreciated. It has more than 10 years in the service. The same for the equipment. Equipment lifespan for their batteries, as an example, we are talking about monitors, ventilators, and other equipments. The lifespan is end and they need to be replaced or fixed. The same for some of the consumables. It is not available in the local market or even in our stock. So we face many problems. Also, we are talking about lack of EMS data system. Wireless communication also is weak. Also, we are talking about the operation, central operation room is not activated. We need to activate it. There is a need for developing the infrastructure of the main 5 ambulance stations in the Gaza Strip. Establishing the 5 ambulance centers, including 2 centers for the PRCS. These centers, they don't have a parking area, washing and cleaning, disinfection and maintenance area, the fuel stations, and this is also make challenges. Especially in the pandemic of COVID, we face many problems regarding cleaning and washing and disinfecting the ambulance vehicles. We have gap in staff training because we have fragmented training. We have a good training program, but it needs to be more organized and more specified. We are talking about the priorities now. As priorities, we put the first priority for wireless communication, which is the backbone of any EMS services all over the world. So communication is very important. It decreases the responding time. It also gives the hospital alert, which make more better outcome for the patient and for the healthcare staff as well. We would like to here to increase the coverage, the area coverage for the current wireless communication system, which is less than 60%, to become 95% or more. Also increasing the number of handset and the vehicle mounted central communication units. The second projects, we are talking about computerization of ambulance services, the hospital services. This project is vital because without data we are blind. We don't know how the system behave. We don't know how the indicators, our indicators, where we are standing. So it will help us for providing statistics, providing indicators, providing all information needed for improving the outcome of the services. The third project is talking about the central operation room. This central operation room will make more and better coordination between all healthcare providers, link the ambulance stations with the EDs in the hospitals, and this will make the better performance for the pre-hospital emergency services and link it with the emergency department, so the doctors in the emergency department, they know that they have an events, an scheduled events, or even a single case if they have to manage this case in a better way. So the pre-hospital alert is one of the most important issues for us and as a pre-hospital and for the hospital EDs, and also make better coordination, prevent duplication of work, and decrease the cost of the services. The fourth project talking about renovation and redeveloping the infrastructure of the main ambulance stations. And this is the bulk of projects. We have here talking about providing the MOH with 20 ICU ambulance vehicles and 30 basic ambulance vehicles, because as we said, that our ambulance vehicle is depreciated and we have to change it. And the running cost becomes very, very high. Also providing 50 main ambulance codes. This is the main code for ambulance. Most of these equipments, like codes, like equipments and spare parts, as we said, it is donated since the previous war in 2008-2009. Also, we are talking about developing a parking area for our ambulance vehicles. You know, the heat and the sun rays and all these factors will affect the ambulance vehicles and the equipment inside the ambulance vehicle. So we are in need to develop some centers by providing a parking area or establishing a parking area. As we said, establishing cleaning and disinfection area for the main ambulance centers. We are looking for establishing at least 3 fuel stations at the north area, southern area, and the middle zone. And this is done with our emergency department. Oxygen refilling station and also maintenance, free maintenance station at the same areas. This will improve the outcome of the ambulance vehicles. Here we are setting the estimated cost price for each of these sub-projects to make it more easy for the marketing and for the donors and stakeholders to know. Also, we are talking about the fifth project, which is the electronic patient records. This will facilitate and enhance database system and the information system regarding the statistics and all information regarding the patient's disease, research, study, auditing, and making good statistics regarding the information we have for our EMS. The last project is regarding improving our staff education and training and performance skills, and also to ensure the scope of the practice and to ensure the quality of services provided for our patients and victims through improving the training and training skills of our staff. And we are talking here about the main and the basic skills and basic training courses needed for our staff. Also, we are going to develop 2 teams, one in the Gaza and the north, and the last one in the southern area. And this will improve the quality of services in the field regarding dealing with mass casualties and dealing with incidents, big incidents and big scale incidents. This will improve the outcome of the EMS services. And here the last slide. Sorry to take more time. This is the summation of the whole projects, the 6 projects, which show the total cost of these projects. And thank you for listening to me.
Thank you, Ashraf. We apologize for the delay we have in the timing of the session, but we will move to the last presentation, which will be conducted by Dr. Iyad Abu Karsh, and he will present to us the care now inside the ICU or the operation theater. And Dr. Iyad is a very well-known anesthesia at the Ministry of Health. Dr. Iyad is the director of the critical care department at the General Administration of Hospitals. Dr. Abu Karsh also is a very well known instructor teaching the ICU courses, and it's our pleasure to invite him for his presentation. Please, Dr. Iyad, floor is yours.
Assalamu alaikum. Hi, everybody, my colleagues, ladies and gentlemen. We are talking about the ICU and the situation in the MOH for this service. As you know, we have a very humble service for critical care in Gaza. We are talking about 2,200,000 people, and they have just only less than 4 ICU beds for each 100,000 of population, which is far from the international standard for around us as in Gaza. Even if in Gaza we have just most commonly this service is due to surgical, post-surgical, traumatic, or even there is no specialized ICU like neurosurgery after neurosurgery, or even cardiac or others like nephrology. Gaza, or all hospitals in Gaza, they have no ICU for high dependency unit, which we call intermediate critical care unit. So you can imagine that this service, we have just only 156 ICU beds, just only from them 19 for pediatrics. And if we said that we have 400 pediatric beds in all hospitals, so at least if we simply calculated 10%, so we need for these pediatrics at least 40 ICU pediatrics, and we have just 19 from them. Of course, as you know, a lot of things that we have according to the policy and procedures, protocols, that's not updating. A lot, we do not have unified guidelines, protocol, even approach team, which is essential for the quality safety for in this critical care. And as you know, because the siege and block for Gaza, a lot of these equipment was essentially in ICU, like ABG, arterial blood gases, like flexible bronchoscope, which is essentially for each ICU. We have a huge shortage in these. And even I would say that we had deficit like flexible or ECMO, we don't have like this. For this reason, if we make some of these priorities as this service, I would choose this pediatric ICU, new established project in Nasser Compound Hospital. I just want to review why it is very important, because you know that in Nasser Hospital, in Khan Yunis, they are serving the Khan Yunis population, more than 160,000 children, and they do not have any of these ICU beds. Can you imagine that a lot of children that they are on hemodialysis, like 12 children monthly, they have at least 2 or 3 times weekly, and this can need for ICU after. I'm talking pediatric ICU after the hemodilution and hemodialysis, and diabetic from these pediatrics, more than 22 children, and always diabetic. You know that they have uncontrolled glucose level, so they need pediatric ICU. What about congenital heart disease? We have in Khan Younis more than 290 children with cardiac heart disease. Let's make these very important to establish this. Who will be benefit from this? Of course, as you know, expected indicator on this, it will be at least 5-6 beds presenting of unified guidelines for pediatric ICU, pediatric critical care approach. And just I want to say that unfortunately, not of these pediatric who are works in pediatric ICU, they are not specialized for intensive ICU. They are just general practitioner or even boarded pediatric. So it is mandatory to enhance the skills for these people, staff in Khan Younis and in other hospitals. This is the first project. The second project that in a Shifa Compound Hospital, as I'm talking that in a Shifa Hospital, there's 700 beds, and just you can imagine that they have 20 ICU beds, and this ICU bed just giving service to trauma and post-surgical. But what about medical? We do not have any of these ICU critical care for medical patients. And you know that in Shifa Hospital, there's 291 beds for internal medicine disease, and none of this, they have any of this critical care for medical patients. And unfortunately, there's no service for high dependence unit, which can be service for this medical. That's mean in Shifa Hospital, we need to establish and to set up this critical care for medicine. I'm talking, especially when you know that more than 27 of patients who was admitted, they are above age above 75 years, and these all patients have comorbid disease, and they need, as you know, hypertensive and controlled diabetes, all these things, CVA, and there is about 485 who are on hemodialysis in Shifa Hospital from all the area in Gaza, who may need after hemodialysis critical care, special closing critical care. So they need high dependency or intermediate for critical care medical patient. The last project that during these 15 years block in Gaza and siege, there was a huge shortage and deficit on organs that may need it. Anesthesia department, ICU department, which is essential, and we are talking about safety for patients, which is one of the most much in Gaza. So I want to talk that about 15 years ago, that was the last anesthesia machine for all this operation room. There is a deficit in monitoring, which is mandatory, had CO2 level monitoring, and unfortunately we do not have. So again, huge shortage and deficit in these all hospitals make us give this project and investment in this project for improvement in these hospitals operation rooms. As we talked that the shortage of ICU doctors, specialists in all the world, especially in Gaza, I would say that we have just 35 and they are boarded, and the others, they are in the program for ICU training. What about pediatric intensivists? We do not have any of these subspecialists, ICU and pediatrics, or even we do not have subspecialty ICU doctor for nephrology, pediatrics, or adult. So it's mandatory to improve the skills, and I think we need to invest in scholarship for these doctors. Again, laboratories, medicine consumable, which is highly needed in ICU and mandatory. Again, we have a huge shortage of this consumable. Thank you, gentlemen. You can engage now the humble service for critical care in Gaza, and I hope that this gives you some picture about this. Thank you very much.
Thank you, Dr. Iyad. With this, the three speakers for the first session have completed the presentations, and we will have, due to the time and the delay, we will have few questions if you have in 10 minutes maximum. So please, if you have any question for any of the presenters, you may write in the chat, or you may also raise your hand if you are through the Zoom. I don't see any hands. Anyone has any question, please pop in. You can pop in and ask your question.
Hello.
Yes, Dr. Yunus, go ahead, please.
Yes, thank you so much, Dr. Abdel Nasser. Just my questions for the first presenter, Xena, which inform about the percentage of the health facility deliveries, and she told that 63% of the whole deliveries occur in the governmental health facilities. It will be better to inform about the percentage of the whole deliveries all over Gaza, that according to what we know, that more than 95 or more than this percentage occurred at the health facilities. This is just to make attention for this point.
Okay, well noted, Dr. Yunus.
Yeah, thank you.
Any other questions? If not, then
Abdel Nasser, this is Elena speaking. May I also step in here?
Please go ahead.
Thank you very much, and good afternoon, and thank you very much to Ministry of Health and colleagues actually to organizing this very useful actually gathering, and I'm really very pleased to be part of this. And as a UNICEF, we also have been supporting the response and the health system in Gaza a lot. Thank you very much for the presenters. Presentations were very actually informative and very good. Provide us a good idea on the needs and gaps. My question is actually, are there considered also needs for the harmonization of the equipment at the emergency unit, or standardization of the emergency unit? It has been actually mentioned several times that actually emergency units require upgrade and standardization of the service delivery, etc. I wonder also if you consider the maintenance of equipment, standardization of equipment, which could be really definitely actually very useful for all partners, to follow, to support the Ministry of Health to standardize the services at the emergency level. I'll stop here and thank you very much.
Thank you. I think, Dr. Attar, you have spoke about the uniforming the policies and procedures, protocols, and by uniforming that would entail also the use of certain equipment in emergency department. So maybe if you want Dr. Attar to comment on Selena's question, if you are to standardize the equipment within the emergency departments, so partners can, if they want to support, they will support something standardized. You want to add? Dr. Attar.
Just now,
Repeat the question for him.
Selena is asking if you are going to standardize the equipment within the emergency departments. So if partners will help you, or they have the intention to help, if they can use a standardized equipment, so they would know what to help you with, rather than every emergency department has different equipment, different resources. So is there any thoughts of standardizing that? Voice is not clear.
I think the voice is unfortunately is not clear, but yeah, we are going to do that, Dr. Abdel Nasser. We are planning for that, and we are willing to do that.
Thank you very much. I think we will have to move, and I would conclude this session. Thank you all very much, and for participants. But for the ambulance services, just to remind, the priorities for the Ministry of Health has been fallen under communication. They want to improve the communication, wireless communication especially. They want to improve the ambulance computerized system, so to improve the information about the pre-hospital patients' records, to establish central operation room, and let me call it central coordination cell, because we don't want to mix it with the overall operation room that we intend to have. The renovation of emergency medical services infrastructure, new ambulances, about 50, including 20 ICU ambulances, and finally, the capacity building of health workers and staff working in emergency medical services. Dr. Iyad concluded his presentation on ICU and operation theaters with his priorities of mentioning the development of policies and procedures to be uniform in all ICU, MOH ICU units or departments, and also the shortages of equipment, drugs, disposables, and lab resources to support the ICU. He prioritized the pediatric ICU in both Nasser Hospital and Nasser Hospital, and also the critical care beds at Shifa, what we call high dependency units, and finally, the capacity building of doctors and nurses in the ICU to meet the potential increase in needs in these units. With these and answering your questions, I would wish to thank the presenters very much, and to hand over the session to the next session, where our colleague Amani Juda will be the facilitator for it.
Thank you, Dr. Abdel Nasser, and thank you, the presenters. Now we will move to the second session devoted to the MCH services. So due to the delay in starting the conference, just please kindly note the heads of the sessions that the discussion will be only 10 minutes. So as I have mentioned, now we have the second session, MCH. The head of the session is Mrs. Amani Jouda. Amani Jouda is maternal child health and nutrition specialist. Amani has quite an impressive experience working in this field with many international organizations, such as Norwegian Aid Committee, such as WHO, Tertizom, Ard al-Insan. Currently, Mrs. Amani is working with UNICEF as the project manager for the maternal, neonatal, and child health project. So please, Amani, the floor is yours, please.
Thank you, Xina. Actually, it's my pleasure to be part of this important conference that could you please mute? Fatima, Okla, please mute.
Please mute the presenters, please mute the mic. Amani, please go ahead.
Sorry, I was muted. Okay. So thank you all for having me in this important conference, which is will enlighten participants on the main challenges faced of the health sector in Gaza, and would also show the gaps that faced by the health sector as well. For this session, we will talk about mother and the child health session, and this session will include talking about reproductive health services. We'll talk about neonatal care services and the child health services as well. Our first speaker in this session is Dr. Sirine Al-Attar. Dr. Sirine is a senior specialist obstetrician and gynecologist. She is currently working in UNRWA, but she used to work at MOH Hospital, and she used to be an active member in the maternal mortality committee, and also she is a great member of an effective member of the early essential newborn care team in Gaza. So Dr. Sirine, please start your presentation about reproductive health. Please.
Thank you for this kind presentation. Maternal and reproductive health is still in the heart of any medical services in any country. Our reproductive health needs during the next generation. I will not mention the ideas my colleagues already mentioned regarding the social determinants of health in Gaza and regarding the high density population, but I will concern in the high fertility rate of the Gazian community, which reached almost 4 total fertility rate during to the multiple indicator cluster survey during the last year. Also, I will mention that we have 60,000 delivery per year, about 2/3 of them in the governmental maternity hospitals. For the gaps in the reproductive health services, I will mention that every part of the cascade, we have one gap or more in it. For the policies and the protocols, despite that we have one national obstetric protocol for Gaza and West Bank, still it needs to be updated. Still, we need to have procedures for it to run on the floor, and still we lag behind the emergency protocols, and there is no incorporation of the Safe Maternal Project or early essential newborn care into this protocol. For staff training, we need continuous training as it one of the areas missing in the training according to the protocol, or in the simulation training for obstetric emergency, and also for the training of midwifery and nursing training. This is the practical training. On the other side, we are lacking subspecialty training in the fetal medicine, in the gyne-oncology surgery, and also in the urogyne. For the equipment and the drugs and consumables, there is a chronic shortage of these items in all the hospitals, like ultrasound beds, laparoscope, but also we have acute on top of a chronic shortage in many essential pharmacological and mechanical aids for delivery, like oxytocin, for example, and other essential drugs. For diagnostic and lab services, I will focus here into three major groups that we are lacking in Gaza. The first one is the genetic lab, which will help a lot in the prenatal diagnosis of multiple congenital abnormalities and syndromes, and will help a lot of patients to not be referred to the West Bank. The other field related to the thrombophilia, either congenital or acquired, as these tests are not available in the Ministry of Health, and it is one of the important causes addressing the maternal near miss and mortality cases. And the other part related to some important daily basis lab tests, which are mostly many times lacking in the hospital labs, like quantitative pregnancy test or like hemoglobin A1C test for diabetic pregnant ladies. On the other hand, I will mention the infrastructure of the hospitals. According to the UNICEF mapping done during the last year or 2019, Harazin, Al-Aqsa, Al-Emirati, and Kamal Udwan Hospital are serving very large population, but they need space extension to accommodate this enlarging number. And also Shifa Hospital, and despite we have a new building, the old building, which they should to run together, is need very urgent maintenance, as its system or maintenance system need urgent interventions to be suitable for the patients. Other parts that we addressed during the last year related to COVID-19, the isolation ward, the logistic support, we face a lot of trouble in it. We have chronic problem related to anemia, as my colleagues mentioned in the early afternoon, that it's about 40% in the pregnant population. We are having increasing trend of the cesarean section rate, which need to be addressed and to work on it, and also the inception of fetal medicine services and gynecological oncology services, as mentioned before. So to address these gaps, we have some suggested projects to highlight with you. The first one is related to the integration of sexual and reproductive health, including adolescents' health, into the primary health care units in the all Ministry of Health facilities, and also all the partners which provide primary health care facilities. The beneficiaries of this project will be all the women at reproductive age and all the pregnant women, which are about 500,000, and we can add to them the adolescents, boys also, which will get benefit of this integration. The current indicators related to the admitted indicator from the Ministry of Health reports and from the multiple indicator cluster survey report, the unmet need for family planning about 11%, the adolescents fertility still about 48 per 1,000, anemia at the range of 40 as mentioned, high risk pregnancy about 1/3 of the cases, and there is no clear indications regarding the coverage of antenatal truly in the Ministry of Health, and we need to introduce the preconception care services in the Ministry of Health. These will include integration of preconceptional care, antenatal care, postnatal care, family planning into the Ministry of Health to improve women's health and to reduce the unmet need for family planning and also to decrease the adolescent fertility rate. All these, we are expected to get the results of integration of primary health care services with the sexual and reproductive health into more than 80% of facilities, decreased percentage of unmet need and anemia by at least 1/3, and also at least half of our pregnant lady will receive preconceptional care before their pregnancy to avert their risk factors during the antenatal care. The second one is related to the sustaining life-saving sexual and reproductive health services, increased preparedness, resilience of Gaza community and health system to crisis, including COVID-19. COVID-19 really explained to us that we have many gaps in our system relating to pregnant women. As I mentioned here, twofold increase in maternal mortality cases during this year relative to the same period of the last year, which could be attributed to COVID-19. So we need to highlight this issue and focus on the gaps in it. Also, we need to highlight the poor access of services, either the physical during the mobility restriction or during the escalations, and also the shortage of supplies in the primary health care for the essential MCH services in about 55% of facilities. So to improve emergency preparedness and response of the health system and community in the Gaza Strip, and to enhance proper referral and network connection of SRH services among various providers and level of care, we are facing a huge problem of fragmentation that we need to incorporate our system with other care providers and other partners to reach a comprehensive package of care for the pregnant ladies behind reaching the hospitals or any need of any reproductive medical care. The third project is related to improving the management of high-risk pregnancy cases, and it will address all pregnant ladies and adolescent pregnancy. As I mentioned, high-risk pregnancy, about 1/3 of our pregnant population, and there are numbers or proportions of many medical comorbidities that we need to address. Our maternal mortality ratio was in 2019 about 30.8. My colleagues mentioned in the start that during the last year it was 24.4. This decrease is not a real decrease, rather than a normal variation from time to time, and it addressed that we need more action and more internal redesign of the package of services given in the hospital. Also increasing cesarean rate, it's about 29% in the Ministry of Health report 2019, and also the maternal near-miss cases. So the suggested objectives will be, first, to define the criteria for monitoring the high-risk pregnancy, and also to evaluate the services are given to them in the outpatient and hospital overnights, also either in the outpatient or the hospital stays, to identify the gaps in these practice, and to try to fill the gaps by the adequate practices, adequate supplies, adequate drugs, adequate monitoring system to improve the cycle of maternal care. Also to address the continuous standardized, well-structured training for a provider, as training is one of the most important issues we are lacking for it now, to achieve the role of nursing staff in raising the mother's level of awareness and increasing their role in the health education of the mothers of the danger sign. Nothing could go on without continuous revision for the well-setted standards. So we want to re-adopt our indicators. We have 15 reproductive health indicators. We want to develop quality standards more, and also to develop performance indicators that monitoring and evaluation will be essential part of the maternal care services all over Gaza with all the levels of care. For the areas addressed before regarding the medical devices, the equipments, and some of the essential needs for the renovation of Shifa or for the expanded the expansion of Tahrir Hospital. It's mentioned here from 1 to 3. Also the rehabilitation of the Shifa building, and I want to mention here that Shifa is serving more than 1.2 million population from the Ghazian population, with mainly concentration on the high-risk pregnancy, with the aim to improve the intensive care and the high-risk care given to them. Also the laparoscopic surgery and the family medicine diploma and the laboratory materials and consumables as mentioned in the lab, in the gaps of the lab. And here again, the labs, medicine and consumable according to the number of deliveries in the Ministry of Health yearly, hoping that you will be with us to save our mothers and our infants and our children. Thank you.
Sorry, these are this issue of a new technology that we need to be unmuted from the host actually. Thanks a lot, Dr. Serene, and for this very informative presentation. Actually, Dr. Serene started by presenting the gaps that included the gaps in policies and protocols, updating operational procedures and emergency protocol. Also, there is a gap in staff training, the continuous refreshment training and subspecialty trainings. Also, she talked about gaps in equipping and supplies, which is everybody knows that there is a big shortage in it. Also about the diagnostic lab services, there is a big gap in it and the shortages, and infrastructure of the maternity units, and of course the COVID-19 management issues, which is faced by logistical challenges. And she stated for that to overcome these all gaps, like about so many projects. The first one was about integration of SRH services in the primary health care and all health facility services, sustaining the life-saving SRH services, and decrease in preparedness of the community and of the health staff and the health system itself. So to strengthen the health system to be able to respond to the SRH services. Also, another project about improving the management of high-risk pregnancy, and this is very important to be happening in Gaza and in Palestine as a whole. Also, there was a project about setting up quality standards, which will all, I think everybody supports to have a quality unified standard specifically for the maternal health, and also we need it will be for all actually health services to have a good standards agreed among all health players. She also mentioned there is a need for rehabilitation, renovation, and equipping the maternity unit, and she mentioned the several maternity units to be rehabilitated. And finally, she talked about the laboratory equipping. Thanks a lot, Dr. Serene. We will go now to our second speaker. Our second speaker is Dr. Shireen Abed. Dr. Shireen is a well-known person in the pediatric and neonate issues. She is a consultant pediatrician and neonatologist. She is currently the head of neonatal Nasser Pediatric Hospital, and she has quite a good experience in 11 years in neonatology and 15 years in pediatrician, and she is also working as assistant professor in Islamic University Medical College, and also she is instructor of several life-saving courses, neonatal life-saving courses at DC. Please, Dr. Shireen, she will be speaking about neonatal health services. Please go ahead.
Thank you, Amani. I'm Shireen. I'm on the head of the GNM or Gaza Neonatal Network Committee. Will introduce the health services needs for 2021-2022 years in Gaza Strip. This is our committee with the head of Dr. Nabil Barkoni. We have 7 neonatal units in Gaza Strip. 4 of them are classified as level 3, namely Shifa, Nasser, Tahrir Hospital, and European Gaza Hospital neonatal units. And in addition to 3 neonatal units which are classified as level 2, namely Shuhada al-Aqsa, Hilal Emirati, and Kamal Idwan. In Gaza, the newborn mortality is estimated to be 14 per 1,000 live births, and have not significantly declined over the last 10 years. Newborn deaths currently represent about 70% of infant deaths, which highlight that the newborn period remains the period of the highest risk for all infants. In addition, 15% of all live births are admitted to the intensive care setting, where occupancy rate is high, leading to sepsis and malpractices when measured to standardized international standards and protocols. In response to this challenge, our Ministry of Health adopted some strategies, mainly early essential newborn care, infection prevention and control, newborn life support, and neonatal safe transport. Those are a package of evidence-based interventions delivered during delivery and in the immediate newborn period. Adoption of these practices and elimination of harmful practices with revision of a newborn NICU admission criteria will prevent and manage many cases of sepsis, asphyxia, and complications of preterm and low birth weight babies. The current gaps will be identified as, firstly, gaps in policies, procedures, and protocols. The update and the scaling of national newborn protocol is essential. In addition to development of neonatal nursing protocol and development of neonatal neurodevelopmental clinic. The second gap in the staff training. On the job and out of the job training courses are essentially needed, and we'll tell you in details in next slides. The third gap is essential equipment. Drugs and consumables are intermittently or continuously lacking, and the list will be provided upon request. The fifth gap is to improve neonatal services, like establishment of TPN or total parenteral nutritional units, to increase the number of incubators up to 180 incubators, to establish 2 fetal medical units, and to introduce vaccination for admitted neonates. In diagnostics and lab services, some lack intermittent or continuous in the blood culture, CRP, GBS or Group B streptococcal screen strategy for all pregnant women, in addition to screening pregnant women for hepatitis and TORCH. Metabolic screening is essentially needed for newborn. To improve our statistics, we need to computerize all neonatal units, to improve registration according to standardized indicators, to improve the work done by the Perinatal Mortality Committee, and to support research to identify context gaps, priorities, and recommendations. Moreover, a list of requirements for the infrastructure is available upon request for each neonatal unit. So here we summarize some projects. The first project is to provide the neonatal unit equipment with essential equipment, supplies, and consumables with beneficiaries of about 7,500 newborns. And the expected indicators are the length of stay, admission rate, mortality rate, and the disaggregated mortality rate. Our objective in this project is to decrease the occupancy rate, to decrease the newborn morbidity and mortality, and to decrease the referral rate, with a total cost, estimated cost of $2,500,000. The second project is to develop, train, and monitor the guidelines with a total cost, estimated cost of $10,000, and objective to improve medical care of the newborn, to develop nursing guidelines, to train 200 staff and to audit and monitor implementation of the top priority guideline. The third project is to develop neurodevelopmental clinics with a total beneficiaries of 14 staff to be trained and 500 newborn with GNN Gaza neonatal network reference. The objective of this project is to apply early detection of neurologic disability in the 7 neonatal unit and to provide the necessary equipment, supplies, and training for the working staff. Scholarship and staff training. We don't have currently any pediatric neonatologist or neonatal subspecialty. So we need a total of 2 doctors and 2 nurses trained or subspecialty in neonatology with total estimated cost of $280,000. The last project is to provide our laboratory and consumables in regard to the neonatal equipment with a total estimated cost of $622,000. So in total is $5,510,000 is needed. And the main challenge here that we lose our babies, especially preterm babies, in addition that we have the local definition of viability of only 26 weeks, and those 26 weeks are almost dying because of the shortage in the staff, because of the shortage of the equipment, supplies, consumables, and the lack of the invasive. So we need your help to improve our neonatal to save our neonates. Thank you for your attention. أنا كنت حطها سلايدات بس بما إنهم حطيتها.
وين الصوت؟
Okay. Yani, sorry, also another time, please, the host be with us in order to unmute us. We lost like about 2 minutes for unmuting. Thank you, Dr. Shireen. Thanks a lot. Actually, this is very important presentation, actually. Dr. Shireen spoke about the Gaza Neonatal Work Committee, which is a very coordinated committee, and its chairperson is Dr. Nabil. She also talked about the neonatal mortality rate, which is not decreasing, in the significantly decreasing in the last 10 years. And she talked about the high occupancy rate at the neonatal units, which is always happening in all neonatal departments. And she also mentioned that in order to overcome several gaps, the neonatal committee has adopted several strategies. These strategies included early essential newborn care, infection prevention protocols, neonatal life support training, and neonate safe transport. These were strategies are adopted by the Gaza Neonatal Network. She also talked about the gaps. The gaps is not far away from the previous prevention gaps. It includes policies, procedures, protocols, staff training, equipping, drugs and consumables, and also a very important issue is improving the management information system, and also added about the gap in diagnostic procedures and lab services, and of course, on top of all of these, the infrastructure. Dr. Shireen has provided started several projects to overcome these gaps. The first project is about equipping the neonatal units with the essential equipment and drugs and consumables. She also about a project there is on a training on the neonatal guidelines, the available neonatal guidelines, or even if there is a need to upgrade this, although I know that the neonatal guidelines has recently been updated by UNICEF. Also, she talked about the need to have a neurodevelopment clinic, which is very important in the, to have such a clinic. Also, she mentioned the need for scholarships and external training for staff, especially the neonatologists, to having more specialized and subspecialty in the neonates. She also talked about improvement of laboratory services. Thanks a lot, Dr. Shireen. I know there might be people thinking of having questions, but we will wait until the last presentation in this session, which is with Dr. Ahmed Shatat. Dr. Ahmed Shatat is a consultant pediatrician. He is the medical director of MOH Hospital, and Dr. Ahmed Shatat is being engaged in all neonatal projects and with all donors who are working in the neonate field and also the maternity as well. So he has a very good and a long experience with the neonatal work. So please, Dr. Ahmed, start your presentation about the child services provision. Please start.
Thank you, Amani. Good evening for everyone. It's broad for me to present about the gaps and priority and challenges of child health service among the children in Gaza Strip. When we are talking about child health service, in the beginning, we don't forget 65 children who were martyred in this last aggression, and our children will, and our children in every time will, yes, and our children in every time will remain and focus on the future to be better future for health and well-being free without occupation. In this presentation, this is the final and the result of working for many days for this member of our committee, was headed by Dr. Yusuf Abou-Rish. In this presentation, I will talk about many direction about overview and challenges and situations and priority and conclusion of this presentation. Overview of situation analysis of child health service in Gaza. In the beginning, you know that about 45% of the population in Palestine is children less than 18 years. Percentage of the population under 15 years of age, about 42%. Percentage of children of under 5 years of more than 60.7%. That's mean our population is young. Early childhood mortality, we about 14 per 1,000 live birth. Infant mortality about 12 per 1,000 live birth. The cause of infant deaths, the main cause of infant deaths are congenital anomalies, respiratory system disease, low birth weight, and heart diseases, sudden deaths, infectious disease, malnutrition, cerebral palsy, accident, and cancer is the 10 causes of the mortality among children. Malnutrition among the children under 5 years, it is the priority and challenge for our population and our children. Stunting prevalence about 8.7, underweight, wasting. This is the main causes of malnutrition for children. Anemia, it is the main the anemia rate for children less than 3 years old is about more than 55% and among school children, more than 37%. What's about functional capability and disability among the children? 2% of our children, unfortunately, between 2 and 4 years, have some type of disability. Disability rate was about 15% among children aged from 5 to 17 years, about 13% in the Gaza Strip. About the policy, anemia, about 70% under 1 year. Shortage of drugs, this is the main cause. Shortage and poverty, this is the main cause, and malnutrition. Updated nutrition guidelines and monitoring implementation. Fragmented early childhood development guidelines not adapted to a national context. No clear referral pathway for children. The child health protocols are outdated. No clear platform to extract child health indicator for action and decision making. About the staffing, our field among pediatrician and pediatric services is suffering from shortage of well and experienced staff and protocols and training programs. This is, we hope to be focused on training on protocol manager on monitoring of implementation, training and coaching staff at primary health care on integration medical child illnesses, training and coaching staff on neurodevelopmental skills and early detection and prevention of disability, training and coaching staff at outpatient clinic and hospital, coaching staff on national early childhood detection protocols, on job training on child health protocols, coaching staff on operation definition and up-to-date indicator. There is a critical shortage of all pediatric subspecialty like oncology, endocrinology, pediatric cardiology, ICU, pediatric neurology, and other subspecialty pediatrics. Equipment, this is shortage for sustained early child development rooms in primary health care and outpatient care in hospital, IT equipment. What's about the drugs? Still, we are losing many units and many children due to shortage of essential drugs like essential antibiotic and essential like surfactant among units. The current gaps of children health, what's related to diagnostic and lab services, still the long list of shortages in laboratory, it is unfortunately big. Infrastructure among the hospital, pediatric hospital, and primary health care need more supported and renovation in many hospitals and rebuilding some building for pediatric hospital to extend the number of beds among this hospital. We proposed that the first project for children healthcare services we propose to be prevention management of malnutrition and deficiencies among children under 5 years. This is first project beneficiaries about 250,000 children under 5 years. This is target group of children. Expected indicators after implementation of this project, we hope to improvement by 10% from the baseline about the health and nutrition status of these children. Project objective to decrease incidence of nutrition problem, to development national committee to update guidelines, to perform on the job training on guidelines, to provide the necessary drugs and supplies. Second proposed project, early detection disability among children and neonatal children. Beneficiaries about 50,000 newborn and children and 50,000 families and 300 MOH staff. Third project, update and develop a child health protocols to maintain equality of the care and support unifying implementation of the protocols and to save children in all of our hospital according to this protocol. Fourth project, health information system to strengthen health indicator development, to produce updated core indicators for children health. This is essential and needs to control our progress and our implementation and to reach our indicator to control our situation among the health children health care services. Fourth project about to create opportunity for training and education specialization, which we mentioned in the previous, like shortage in all subspecialty of pediatric subspecialty. This need for support about 14 doctors and 6 nurses in subspecialty of the pediatric subspecialty. What's about Rantisi Pediatric Hospital? This is the central specialized pediatric hospital. Needs of this hospital, which need to provide and supporting this hospital by many equipment like digital X-ray and EMG center, gastrointestinal endoscopy, water dissemination plant, CT, rehabilitation department, construction of Al Nasser Hospital, specialization which need for this hospital to support all of our pediatric system in all the Gaza Strip, pediatric surgery, pediatric orthopedic, pediatric urology, gastroenterology, pediatric nephrology, pediatric neurology, genetics, and metabolic disorder. About laboratory needs for pediatrics, list of the laboratory shortage is big, and this is the list of essential to maintain the minimum safety for the service of children. Consumable like that. This is only for Rantisi Hospital. Thank you very much for your listening, and this is the summary of our projects. Thank you.
Thank you, Dr. Ahmed. This is also very informative, actually. In summary, Dr. Ahmed mentioned the gaps, and I would like to just inform the main things that about the IMCI guidelines and staffing, the ECD guidelines, equipping ECD rooms, IT and the drugs and consumables, and of course the infrastructures comes always in the top. The main project we're talking about management of malnutrition protocols of children under 5 and the early detection of a child disability, updating the child health protocols, and of course the health information system improvement. And also everybody is asking about subspecialty and training for doctors and nurses, and there was a special mention about Rantisi hospital needs. Thanks a lot, dear 3 presenters, and this is very really informative. I would like to open now for questions. I can see there is a hand raised by Osama. Please, Osama. Osama Abu Aita. If you want to unmute Osama, the host. The host, could you please unmute Osama? Is it Xena, the host, or Shireen?
Yes, I think I'm in now. You hear me?
Yes, yes, we do. Please,
thank you,
Osama.
Amani, and thank you, the presenters and the Minister of Health for this important conference. I don't want to waste more time. I'm just want to pick up on one point stemmed from the conference name, the anticipation. I believe every presenter in this session and others will provide very good details on the challenges that are well known and can also be even more updated, because I noticed some figures might need some update. But anyway, let's talk about the opportunities. And since Aksina and Dr. Ahmed also pointed out the how big is the slice of young people of Gaza Strip, I want to emphasize on the intention that we heard about. The Minister of Health is going to open a department and to introduce the adolescents and youth health services as part of its main services and function. This is very good indeed. And I would also like to emphasize the point that we need to put our feet on the ground and build on whatever we have. We've been going through bureaucratic crisis since many years. So I think all the standards or the protocols that we are developing should encounter this and build on the basis of that. We are not expecting something to come from outside or to fall from the sky to leverage our baseline. Our baseline and the challenges are there, and we need to encounter them. Another point is, I believe the Minister of Health needs to really invest more. I mean, they are doing well in that, but maybe to invest more on improving the accountability and bridging the gaps between the standards and the practice, because usually there are some gaps between what is set in the protocols, whatever standards, and the practice, and this can be easily, or at least the entry point to that is the increasing the supervisory mechanisms and also giving incentives and giving credibility and the credit to different colleagues. My last point is, I think under the leadership of UNICEF, WHO, UNFPA, and the Minister of Health and all health workers, and the presence of many joint projects, including the French project for maternal and child health, I think we can do better and we can improve and leverage the MCH and sexual and reproductive health services and information to all. Thank you. Over.
Thank you, Osama. This is very important, actually, and informative as well. Dr. Yunus has a question or a comment. Please, Dr. Yunus.
Open the, give me the...
Please, the host to open, to unmute Dr. Yunus.
Please.
The host. Try Dr. Yunus or what?
Hello.
Okay, yes, we hear you.
Okay, okay. My question for Dr. Shireen Abid. Thank you very much for your presentation, and I am happy that you are informing the needs for the TBN and metabolic screening labs and the creation of the neurodevelopmental unit. As these activities will fill the gaps to be able to provide quality health services and assist in reducing the neonatal mortality. My question is in two questions about the updating the national neonatal protocol, which is, I think it is done with different organizations by the assistant of UNICEF, and I think what need more for the updating this national protocol. The second, you inform about the capacity building of the staff regarding to the needs for the pediatric scholarship for the pediatric neonatologist and the other subspecialty. You ask for two staff and the other two staff. Is it enough to cover all the neonatal department? Over to you.
Okay, thank you, Dr. Yunus, for your comments and questions. In regard to the neonatal national protocol guideline update, as you know, you was one of the partners in UNICEF in addition to other partners, and we built the national protocol on a few guidelines, and there are many other guidelines we need to develop in addition to update some. The main gap in our guidelines was in the nursing protocol. We don't have a unified, comprehensive neonatal nursing protocol. So this remains the main challenge, and we need to build on the medical to be comprehensive with the nursing guideline. The second question is about the capacity building and the staff, whether the 4 staff are enough to cover. Of course, no. This is this project only for 2 years, and after then we build on another staff. We can send many staff to study subspecialty. So we start with this, and then annually or each 2 to 3 years we send another till the most neonatal units are covered with neonatal specialties.
Thank you, Dr. Shireen. Thank you, Dr. Yunus, as well. We have Dr. Selena from UNICEF also would like to say a question. Please unmute Dr. Selena.
Thank you, Amani. And thank you very much, Dr. Shatat and Dr. Shireen, for a very good presentation. I will just I'm so happy actually to hear from both of you a lot of familiar projects and initiatives that are very close to our heart. Because UNICEF has been engaged in support to mainly all listed projects and initiatives. Together with you and under your leadership. I would like actually to pick up on the point which Osama mentioned. He mentioned actually our joint initiative in strengthening the health system in Gaza, coordinated among the UN partners, UNICEF, WHO, UNFPA, and under the leadership of Ministry of Health. And I do believe that should be approach which we have to use for the future work, and in order actually definitely to strengthen the system and to have development and the humanitarian component strengthened in the same time. Because actually Dr. Youssef Aborish, he mentioned in his opening remarks about the humanitarian and development nexus and the importance of working towards the system strengthening. And I do believe that all of us actually, it has been again confirmed during the recent war actually that only with health system strengthening approach we could actually support Gaza people, children, women to access quality health services in all kind of context. And I believe that we learned a lot through actually implementation of AFD supported project. But I also, I'm sure that we have to continue. And this is also invitation for all other partners definitely to think, to have the big picture and to support the development of the health system rather than actually focusing on the small project and only on the responding to the emergency needs. I'll stop here. Thank you very much, Maya.
Thank you, Dr. Selena. This is very important actually to utilize the resources that we have currently and have a joint integrated programs together in order to build the capacity or to strengthen the system to respond to such exhausting and overwhelming services. I can't see any hands raised. That means nobody is going it's having a question, but there was a comment in the chat that's saying it's from Dr. Najib. It's saying that it could be good to have a partnership with one of the selected academic centers to support the training and the specialties in our context. So thanks for all, and back to you, Xena, for presenting the third session.
Okay, Amani, thank you very much for heading this session and for the presenters participating in this session. So given the delay and time restrictions, we are moving ahead to the third session devoted to the cancer and palliative care services. So this session will be led and managed by Mrs. Maha Al-Banna. She is working as a program manager for Qatari Red Crescent Society. Mrs. Maha has a Master of Public Health in Health Management, and she has quite a good experience in working in the humanitarian field with a specific focus on health intervention. So please, Mrs. Maha, the floor is yours, please, go ahead.
أنا هنا على أي حساب أنا؟ على حساب شيرين. All right. Can you hear me, everyone? Good afternoon, and thank you for joining us. We're ahead of the third session, which is going to be talking about cancer and palliative care. As we all know, cancer is a major public health problem and the second leading cause of death worldwide. Now, this situation is further aggravated in Gaza by many factors, mainly the closed crossings. The closed crossings can prevent patients who need advanced interventions from leaving Gaza and receiving such necessary care. Now, in the next session, we will have three great presentations that will tackle the issues of breast cancer service, oncology and hematology service, and palliative care. I will be introducing our presenters, but in order to prevent any further delays, I will not be summarizing the sessions, especially that the presentations will be shared to all participants via email. So we will start with our first presentation, which will be given by Dr. Karim Batniji, Consultant of General Surgery. Dr. Batniji is head of breast surgery unit at Al-Shifa Hospital in the Ministry of Health. He has a great experience in this field. He's the Consultant General Surgeon, breast cancer surgeon, core member of the Breast Cancer National Committee. He's a member of National Breast Cancer Committee and lecturer of surgery at medical school. So without further ado, the floor is yours, Dr.
Good evening. So we are going to talk about the breast cancer services and needs. Okay, so our committee is actually comprehensive to go in line with the nature of breast cancer services. So those are the main points we're going to talk about. Now we have a glance about the status quo of breast cancer services in Gaza, the current gaps and our needs as well. And we will determine our priorities in the next coming future. Breast cancer is actually not only a clinical problem, but it is a growing public health and policy concern because of the increasing incidence, especially over the last 10 years. In Palestine in general, breast cancer represents about 15% of all cancer cases registered annually. Between 2014 and 18, more than 8,000 cancer cases were registered. This makes it more than 1,000 cases per year. Breast cancer among them was over in 2019 the most common type of cancer incidence, accounting for about 17% of all newly registered cancer cases, with an incidence of 20 persons almost per 100,000 population. Among ladies, breast cancer presents about 33% of cancers. This means that 40 ladies out of each 100,000 ladies in Gaza are going to have a breast cancer each year. Unfortunately, the 5-year survival rate of breast cancer patients is as low
We are back again, and sorry for the connection issues. So we're going to address the current gaps of breast cancer service that can be summarized as follows. First of all, we have gaps in the policies and protocols that standardize the whole breast cancer service, starting with the most important one, which is we need to set up standards and protocols for breast cancer screening and early detection, as well as the referral, together with the improving our already existing guidelines for management of breast cancer. And we need other policies for surveillance of breast cancer patients. Another important gap is that we need adequate number of care providers in breast cancer service to cover our needs among the multidisciplinary nature of breast cancer service. This requires us to recruit a sustainable training for breast cancer care providers. We need adequate and appropriate equipment to cover our programs, especially the screening programs. This entails having adequate number of functioning mammography machines, ultrasound machines, MRI and CT scanners, as well as the more advanced PET scanning. And of course, we need to have the necessary laboratory machines. Talking about the gaps in drugs and consumables, it is already known that we have almost 40 to 60% shortage of the important oncology medicines around the clock. Importantly, here in breast cancer, we are talking about shortage in chemotherapy and biologic therapy and direct targeted therapy, as well as radiation therapy is unfortunately totally non-available in Gaza, which is an integral part of a breast cancer service, especially the treatment of breast cancer patients. Again, we need to make sure that if we need to perfect standardized breast cancer care service in Gaza, we need to make sure that all the necessary equipment and facilities and resources are available, starting with the appropriate imaging modalities and not ending with linear accelerators and isotope scans. We were dreaming of having this breast cancer service under one roof in the form of a breast cancer service center. This will solve a big problem, which is the fragmentation of service that is already existing. We need to invest more and depend on improving our human resources. An important issue as well is to have our national database registry for breast cancer screening, just to know where we are and what is being done, and to overcome the problem of duplication of services at the expense of other ladies who do not have their screening. Other important issues that are recognized to be among the gaps is the intersectoral collaboration. It already exists, but we need it more efficient and together with the Ministry of Health to have the best service available for our patients. An important problem is the awareness of ladies as well as their family members, the gentlemen. We need to raise the point about the importance of early detection of breast cancer. One of the important and pivotal aspects of breast cancer service at the breast is the palliative care. And our friends are going to talk about it in details in this session. Also, psychosocial support and rehabilitation is needed to have an optimal breast cancer service. All this needs to be under clinical governance. So we prioritized our gaps, and the top priority is for setting standards or protocols and a program for early detection. This means the screening and proper referral guidelines for breast cancer to cover all southern governors in Gaza. We expect this project to be done and working over the next year, inshallah. It is definitely all ladies in Gaza who are eligible for screening will benefit from this project. We knew that we need such a program, which is the screening program, because of the increasing incidence of breast cancer, which is already known. Also, the high mortality rate is another indicator. people or patients with breast cancer present late because of the stigma and the lack of awareness. Also, the number of diagnostic machines is not up to the what we are looking for. The number of high quality and high volume staff in the aspects of breast cancer care service. And also, we need all this to be done through the appropriate guidelines and clinical standards. We expect from this project that to reduce the incidence of breast cancer by early detection and awareness. So in turn, it will reflect on saving patients' life and preventing the disabling morbidities. Among our expected indicators is to build our capacity, the capacity of the team members dealing with breast cancer service, also to have a unified database registering the breast cancer screening service. Our objective actually is to develop a screening and referral guidelines and to train all the personnel involved in breast cancer service, the multidisciplinary nature of this service, and to allocate our resources to ensure that it covers all the governorates equally, and also to educate women and spread the awareness about the breast cancer among women and gentlemen as well. So this is our top priority, which is setting up a program, comprehensive program for breast cancer screening and early detection. A second priority on the list is development of national database for breast cancer screening. And we expect this to take 6 to 12 months. So next year, we should have it, inshallah. Also, again, the population was going to benefit from this service is all women who fall in the group of eligible for screening. Our current indicators for this project is that screening is being done in Gaza, but we do not have a definitive number of ladies who were screened. And of course, we expect that we are going to be able to determine the coverage rate and of screening activities, and to be able also to determine the early detection rate among the screened population. Our ultimate goal is to cover at least 70% of these ladies, the 144,000 by 2025. Our objectives here are to establish a national database for breast cancer screening and to follow up the screening, as well as to perform clinical governance on the available services. A third priority is that we need to know where we are and what do we have actually through mapping and assessment of current screening services and service providers. We expect this to take 6 to 9 months as well. All risky groups will benefit from this project. We knew that we need such mapping because the only available mapping that was done with joint effort between MOH and UNFPA in 2017, it only mentions that we have 17 mammograph machines with no further details about the capacity and functional status of each machine. We expect that we are going to identify the available resources for screening and their ability to function. Our objectives from this program is to assess the availability and ability of a screening equipment, as well as to present this service throughout the 5 governorates. Also, we need to develop an assessment tool for the functionality, capacity, and expected average year for each device and piece of equipment, and of course to reallocate and prioritize the needs according to the shortages. So to sum, we need those to be covered. Some laboratory issues, providing laboratory materials, consumables, and medicines, and as well as consumables necessary for breast cancer service. Our first priority is the screening and the referral guidelines. This is done through developing national Palestinian the early detection and screening guidelines and referral guidelines. Also to train all breast cancer care providers and to do training. We need to purchase the necessary machines, such as we need an urgent purchase of 5 digital mammographic machines, as well as 5 ultrasound machines, together with the MRI scanner and genetics testing. The second priority is for developing an IT database center for breast cancer screening and control, as well as we need to map and to know what we have through mapping and assessment of current screening providers. And finally, we need the necessary lab and consumables to be ready. Thank you for listening to us again, and I'll leave the mic for my colleague. Thank you very much.
Thank you so much, Dr. Karam. And once again, we apologize for what happened, but as you can tell, this is the story of our life with the power outages, and despite all the precautions we take, connecting our instruments to UPSs and anything that we can do, but still we run into these problems. We were not able to share the presentation, but as promised, we will be sending the presentations of all our presenters through email. So our next presentation, and which we will be able to share, will be with Dr. Khalid Thabit, Associate Professor of Clinical Oncology. Dr. Khalid is the consultant and head of oncology at the Shifa Medical Compound. His experience is great. He has been working in the field of oncology for more than 20 years. He has international publications in oncology, and he is head of the National Committee for Oncology. We are working on sharing the presentation at the moment. And like I said, everything will be sent via email. So just please bear with us just a minute, and Dr. Khalid will be with us soon.
Good afternoon for all of you. We are so much happy just to present the oncology and hematology service needs for the year 2021, 2022. In fact, we will talk about the oncology and hematology needs, of course, and as we know that we are living in Gaza. Gaza is a very overcrowded place with 1060 square meter as an area, the 2,000 population, and we are having an increasing incidence of cancer cases in Gaza per year, and we have the last statistics showed that we have 90 cases per 100,000 population. We have a lot of challenges related to the cancer services in Gaza, served with a lot of gaps due to the deficiency of important services, which need comprehensive and radical solution. The current gaps in oncology and hematology service in Gaza, the policies, procedures, and protocols. We have no screening program for the colorectal cancer in Gaza Strip. There is no structured team for the colorectal cancer screening program, and the health education is also deficient. But regarding the staff training, the shortage of staff training for the conduction of the for the screening. Also regarding the equipment, the most important thing that we don't have radiation therapy machines or facilities in Gaza, and shortage of colonoscopies for the healthcare facilities, the drug and consumables. There is always a shortage in drug and consumables in Gaza by a percentage ranging from 40 to 60%, particularly for the breast and colon drugs. The diagnostic labs, of course, we don't have an advanced immunohistochemistry testing and molecular testing for the cancer and colorectal cancer and the breast cancer, and this leads to hasten the decision for the chemotherapy or the other targeted therapy. Also, the infrastructure in Gaza, we are lacking a full structured place for the cancer service. For example, we don't have a national cancer hospital or a national cancer center for in order to gather all the services of cancer therapy under one ceiling, and this has a lot of drawbacks on our practice. Of course, we have a lot of here projects. Of course, the first thing is that we are seeking of establishing a cancer center where all the facilities and all the services of cancer will be under one ceiling and the same building. And this has been recently agreed upon the Minister of Health and Islamic University to be the Turkish hospital. And the Turkish hospital, the project will be falling into 3 domains. The first domain is the reconstruction and rehabilitation of new cancer center in the Turkish hospital. Why this? Because we have an increasing number of cancer patients per year, and the hospitals allocated for the cancer services, they are overwhelmed, and they are overwhelmed by a lot of patients, and always we are falling short with the always we are falling short with the shortage of the beds in these hospitals. The first project would be establishing a new building for the radiotherapy center in the Turkish Friendship Hospital in Gaza. The second project would be providing a new furniture, medical equipment, supplies and instruments, medical machines, and reconstruction of the current for the current cancer center in the Turkish Friendship Hospital, because we are in need of remodeling of the most of the departments of the hospital in order to make a place for the outpatient oncology clinics and for the outpatient chemotherapy daycare facilities and daycare service in the Turkish hospital. And the third thing is the establishment of the radionuclide facilities like the PET-CT scan in this hospital. The project for the radiation therapy center, this project where the time for the duration of the hospital will be 2 years, and as we know that most of the cancer patients they need during their course of treatment of radiation therapy, by about 60% of these patients will require radiation treatment, and because the radiation therapy is not available in Gaza, we used to send the patient outside the Gaza Strip. And this has a lot of drawbacks on the patient regarding the delay and regarding the preventing the patient from leaving Gaza Strip because of the Israeli closure of the borders, and a lot of patients fall into a lot of complications and problems, and a lot of patients sometimes lose their lives while they are waiting for the radiation therapy. If the center has been established, we reduce the mortality and morbidity by 5 to 6%, and we reduce the mortality of the metastatic cancers by 30 to 40%. The expected cost for this project will be around $6,500,000 for the establishment of the whole cancer therapy facility. The second facility would be the re-establishment and the remodeling of the Turkish Friendship Hospital. As I mentioned before, we need to remodel the hospital in order to establish an outpatient clinics for the oncology patients, chemotherapy facilities, chemotherapy pharmacies, chemotherapy treatment halls, and other facilities for the cancer patients. And also we need to provide this hospital with instruments, particularly for the outpatient clinics and for the pharmacy and for the lab for the histopathology, and the total cost will be around 2 million. The third hospital will be, the third project will be the establishment of the establishment of the nuclear scanning at the Turkish hospital, particularly the PET-CT scan, as we know that we don't have this facility in Gaza, and as same for the radiation therapy facilities, most of the patients used to be sent outside Gaza for all the suffering and all the delay, which sometimes cost the life of the patient while they are waiting for these services. The total cost of the project will be $3 million for the establishment of a PET-CT scan machine in Gaza Strip. Of course, in Gaza Strip, we don't have a structured screening program for the colorectal cancer, and we are aiming to start the program for a screening program for colorectal cancer, and this program will be for 2 years, and we will focus on the high-risk patients, particularly high-risk candidates, particularly the relatives of the cancer patients, and this screening program will be spread all over the outpatient, our primary health care clinics in the Ministry of Health. And of course, we need colonoscopies for this project, and we need training for the staff and the training for the technicians for this facility. And the total cost will be around $350,000 in order to cover this program. Why this program is very important for us? Because if we implement this program, this means that 70% of the cancer colon cases will come to us in the early stage, instead of what we are facing now. 45% of the cancer patients in colon cancer, they are coming in the fourth stage, where only little can be done for them. So the screening program for colon cancer in Gaza is a mandatory, and it is very essential in order to save the life of the patients, because as we know from our statistics in the Ministry of Health, the colon cancer comes the first in the male and the second in the female patients. The last project will be the establishment of immunohistochemistry and molecular testing for breast and colon cancer, and this is very mandatory because this will aid us in choosing the best treatment for the breast cancer, the best treatment for colon cancer, particularly in the fourth stage, where we can choose between the new drugs and new lines of treatment, particularly the molecular targeted therapy and the immunotherapy. And this project will cost around $83,000. And also we have a scholarship and staff training. We need an oncology specialty, 2 oncology specialty, and we have 2 hematology specialties, and we have pediatric oncology and hematology 2, and nursing specialized in oncology hematology 2, and nursing oncology diploma 20, with a total cost of $440. In order regarding the laboratories, medicines, and consumables, all these are presented in this slide, and these are mandatory in order to complete our project of establishing the cancer center at the Turkish Friendship Hospital. In order to sum the projects here, we have the first one, the reconstruction and rehabilitation of new cancer center in the Turkish hospital with the 3 subdomains, and the total cost will be around 11 million. And the second project will be colorectal cancer screening project with a cost of 350,000, immunohistochemistry and molecular testing for breast and colon cancer with 83,000, scholarships and staff training for 440,000, and providing the necessary laboratory materials, medicines, and consumables for 1 year, which is about around $7,600,000. So the total cost will be around $19.5 million. Thank you very much.
Thank you, Dr. Khaled, for a really great presentation. As we can see, both Dr. Batniji and Dr. Khaled stated the priorities and the gaps. The efforts made by the MOH here are great, but the challenges and needs are much higher. And hopefully they have provided good ideas for projects that partners can help support. Our last presentation in this session is going to be given by Dr. Hisham Zinati. He's consultant anesthesiology, ICU, and perioperative medicine. He's the chairman of Department of Anesthesiology and Perioperative Medicine at Shifa Medical Hospital Complex, with experience of a total of 25 years. Dr. Zinati has a subspecialization in neuroanesthesia, has experience in anesthesia for maxillofacial surgery, bariatric surgery, and difficult airway. Dr. Zinati is also a member of the American Society of Anesthesiology and Difficult Airway Society in the UK. Dr. Zinati, you have the floor.
Good afternoon. Thanks for your valuable time. I'm going to talk about the palliative care services need for the 2021 and 2022. Palliative care is increasingly a topic of discussion and concern, but not everyone knows what is it and when it would be accessed. Whether you are young, sick, or well, the one thing we all have in common is that dying will be a part of our lives. For those with a serious life-limiting conditions, palliative care can make it a more positive experience. Palliative care can enable people to be comfortable at the end of their lives and ease their concerns and that of their families, allowing them to enjoy their time together. Palliative care can also support medical professionals as their patients transition from receiving treatment that aims for a cure to care that seeks the best quality of life and symptom management. In our talk here, this is the member of our committee, Dr. Ibrahim Murad, consultant pain management, Dr. Bushra Lubad, pediatrician, Dr. Giyad Bukarish, anesthesiologist, Dr. Abdullah Jamal, psychiatrist, Dr. Shireen Ayub, pharmacist, Dr. Hani Samour, intensivist, Dr. Ahmed Sharafa is an oncologist, Mr. Ala Al-Ghalayini is a representative of Norway, and Mr. Ibrahim Ta'qud is a nurse. We'll talk about the overview, current gaps, priorities, and we will summarize at the end. Regarding the overview and situation analysis of palliative care services in Gaza Strip, palliative care as an organized or implemented system in Gaza Strip Ministry of Health hospitals is not yet available apart from a primitive self-supported trials in RNTC hospital by a general team with a limited experience and resources without a definitive place or department, and not funded by any local or international non-governmental organization. Regarding the current gaps of palliative care services, unfortunately, the service is not yet available, and so we don't have any policies or protocols, and there is no specific place to provide this service. And also, we don't have an organized multidisciplinary team for this service. Equipments are also not available, like patient control analgesia pumps, and we have shortage of opioids and other controlled drugs. And the infrastructure is not yet available. Now, regarding the priorities for interventions in 2021 for the palliative care services, our project, we prefer to be an RNTC hospital as it is caring for oncology patients from pediatric and adults. And if it is implemented in a new hospital, if they are a new hospital for this service, we prefer the new hospitals. Those who will get benefit from this service are the adult oncology patient, pediatric oncology patients, and we also can involve the pediatric chronic and life-threatening conditions. The current indicators, I think drug viability, like different types of drugs like syrup, tablets, skin patches, and parenteral injections, intramuscular or intravenous or subcutaneous. We need staff training for a multidisciplinary team, including doctors, like general practitioner and palliative care specialists, nurse, social workers, and physiotherapist, occupational therapy, psychiatrist, pharmacist, dietitian, and pastoral cares from different religious and spiritual and different cultures. We need the training either locally or abroad for this team. And also infrastructure, specific place to be identified for a department with a monitored bed with oxygen source and multiple outpatient palliative care clinics. We need also to implement a national protocols to deal with different types of illnesses, and of course, equipments like monitoring and infusion pumps for analgesic drugs. Now, our expected indicators after implementation of this service in the first year, and inpatient palliative care hospital beds with monitoring and oxygen source, available member of palliative care team 24/7, available opioids and other controlled drugs for a palliative patient 24/7, and available medication for symptomatic medical condition and opioid side effects. Now, the expected cost is not yet specified. It needs financial experience in this regard. Our objectives is to emphasize the need to create a national palliative care policy, ensure secure access to opioids for pain relief, create a palliative care team, training of all healthcare staff in palliative care, raise the awareness and increase knowledge regarding palliative care services in Gaza. Thanks for your attention.
Thank you, Dr. Zanati. Palliative care is becoming of interest. There's a clear understanding of the importance of palliative care for the oncology patients as well as other kinds of patients. But it is still in the beginning in Palestine, but hopefully more attention will be given to it in the future. With this, we finish the 3 presentations of our session. We will offer 10 minutes for discussion. We have been presented with 2 requests for comment, and I will give room for them in order. But please, if you have more questions, do send them in the chat, and we will try to get back to you with answers on that. Our first comment is going to be from Dr. Ibrahim Murad. He's anesthesia and pain management leader at Norwalk, Gaza Pain Management Clinic. Dr. Ibrahim.
Good evening. I'm Dr. Ibrahim Murad, is a representative of Norwalk for Gaza Pain Clinic as a medical doctor for pain in Gaza Pain Clinic implemented in the Shifa Hospital. Gaza Pain Clinic is opened in a cooperation between MOH and the Norwegian Aid Committee in Norwalk at the end of September 2019 at Shifa Hospital, and consists of 2 doctors, 2 nurses and pharmacists, and 1 secretary and administrative. And the team works under a specific protocol and approved by MOH. Our patients go through several stages within the treatment protocol presented for a last 4 to 6 months, estimated by the response of every patient. We started with dealing with our first journey of patients with 117 patients until the 1st of June 2020 as a part-time clinic for 2 days for injured patients from Great March of Return. From 1st of June, the clinic expanded to full-time outpatient clinic with a full-time staff for working days with the new categories rather than injured people. With the chronic post-surgical, post-failed back surgery syndrome and chronic post-traumatic, and the number of patients increases until now 496 patients until today, with a raise of more than 370 patients. We have either multiple follow-up patients visits, and until today we have 2,356 patients as a follow-up patients. We closed 268 patient files after their they finished their treatment protocol and they was successfully ended from our clinic. We have 2 closure after the total curfew of Gaza clinics, first in the August 2020 and the second at April 2001, and this affect our journey of treating people. But we were delivering our patient follow-up medications to home. From the beginning of October 2020 until now, we taking preventive measures for COVID-19 and taking our consideration by restrictive measures as a social distances and temperature check and alcohol sterilization of the hands. Gaza Clinic hope to raise awareness and increase knowledge about pain management in Gaza, and thank you.
Thank you, Dr. Ibrahim. We have room for another comment from Mr. Ahmad Nasruddin. He's the Chief Executive Officer at PCR. Mr. Ahmad.
Thank you, Maha, and thank you everyone for inviting me. At PCRF opened the Pediatric Cancer Center in Gaza at the top of the Rantisi Hospital in 2019, which was the second one in Palestine, the first one in Beit Jala 3 or 4 years before that. Since then, that center has seen 500 children between inpatient and outpatient clinics. I'm happy to report that our success rate between recovery and remission is about 88%. We deal with a blood-based cancer disease. We don't have radiation. We only have chemo treatment. And not only we do that, we also intervene on the mental health part. We have a group of psychologists and psychiatrists that plays a big role with the children with cancer. From a mental health point, we also have 3 social workers at the cancer center that on a daily basis we partner with the King Hussein Cancer Center in Amman. They do all of our testing, blood testing for us, and they help us with training for all levels of staff in the cancer center. And we do some work with St. Jude in the United States. We also furnish all three meals for all the inpatient kids year-round. Our challenge is really is twofold. The drugs availability. We basically, the MOH does not have that kind of drugs or medications on their stock pile, and we basically have to purchase that through donors and through partners. The movement of the kids in case we need to transfer a kid to Jordan or to the West Bank, it's very limited. That's really a big challenge for us. But overall, we're happy with the results. We're happy that we have cut a big chunk of the transfers from Gaza to the West Bank and Jordan and parts of Israel. That's really the summary of what we're doing with the Pediatric Cancer Center. I'm more than happy to take any questions from on that subject.
Thank you so much, Mr. Ahmad. That's very valuable information. We all know the valuable work of PCRF, and thanks for shedding some more light on the exact activities you do. And we hope that more cooperation continues between you and the MOH in order to provide the children with the care they need. I'm not sure if we have any more time, but if there are any questions, please raise your hand or text us in the chat. Otherwise, I will have to give the floor back to Sania for the following sessions.
So it seems that there are no any questions. So we will move further to our fourth section
Dr. Najib
on
is there.
non-communicable disease. Okay, Dr. Yusuf.
Dr. Najib is there.
Hello, assalamu alaikum. Just a very quick question around both the palliative care side and some of the wider health system strengthening side. From the palliative care side, are there any initiatives around home-based and community-based palliative care? Granted, this does not lead to specialized services, but they still do support to provide psychosocial and other aspects of dignity in homes. Is there such a program at all for community-based care? And the second aspect links to a comment I made earlier in the chat about the Human Resources for Health program in Rwanda, which was a comprehensive program to look at medical specialty training across multiple specialties over 5 years. And I think given the broad-based theme around improving capacity of human resources, I wonder if that's a model, if not already familiar with, we can maybe see if some elements could be adapted for this situation. Jazakallah khair. Thank you. Assalamu alaikum.
Any more questions or any more interventions?
Home services is not available. Palliative care, the basis of home services is not available. But regarding the capacity building for staff, we don't have any idea about this.
I guess,
thank you.
There have been discussions about the community-based palliative care, but so far nothing really exists here, but it is one of the options on the table.
Yeah. You can proceed, Sina.
Okay. So we are moving to the fourth session on non-communicable diseases. Dr. Khalil Hamad from UNRWA will head this session. Dr. Khalil Hamad is a medical doctor who has been working in UNRWA for 7 years as the head of one of the health centers, and then has been promoted to the current post of field disease control officer, and has been working in this position for 3 years. So, Dr. Khalil, you are welcome, and go ahead with the presentations for the NCDs.
Okay. Bismillah ar-Rahman ar-Rahim. Good evening, everybody. Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank everybody participating in this conference, and a special thank to the colleagues of health. We have 3 presentations in this. Sorry. We have 3 participations under the topic of non-communicable disease. One will be presented. Yes, yes, Dr. Khalil is with you. Again, welcome everybody, and thank you for your efforts to arrange and run this activity for supporting the health sector in Gaza. Actually, under the topic of non-communicable disease, we have here 3 participations. One will be about diabetes and hypertension health services that will be presented by Dr. Amal Zakout. The other will be about cardiac health services, will be provided by Dr. Mohammed Habib. And the third one will be about renal health services, will be presented by Dr. Mustafa Al-Aila. If each presenter will have 10 minutes, and after that we have 15 minutes for discussion. Now I would like to present Dr. Amal Zakout. Dr. Amal Zakout is the Director of the Department of Non-Communicable Disease. She is a master holder of Master of Public Health. She has been the trainer and facilitator of many programs and many training courses in the Ministry of Health. She holds many certificates in the field of essential geriatric medicine as well as endocrinology. And I would like to present her and remind her that she is having 10 minutes for her presentation. Dr. Amal, are you with us?
Yes, سامعني.
Okay, please go on. Thank you.
بس الشاشة عندي لحظة شوي. طلعت البرزنتيشن هي.
You shared your presentation?
مش شايفة بس البرزنتيشن، مش عارفة، مش طالعة لي.
Maybe you can ask support from our colleague Engineer Ala if he can help you or do co-hosting for you, or you send him the presentation. Engineer Ala, if you can support Dr. Amal, please. Okay. Dr. Amal, the screen has been shared and you can start, please. دكتور أمل؟
وأنا سامعاكم، مش عارفة بس مش قادرة أشوف ال.
The screen is there. We can see it.
Now I can see it. Okay. Welcome everybody. Thank you for this honor to be a speaker in this conference. I would like to talk about hypertension diabetes services needs for 21-22. Next. This is our committee. The head of committee is Dr. Sohail Fishawi, and I'm part of them. Next. 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 Overview and situation analysis of hypertension and diabetes in Gaza Strip. In the Ministry of Health, primary healthcare clinics, we have more than 10,000 diabetic type 2 and around 1,000 type 1 and 14,000 hypertensive patients as registered here in our clinic. Of course, these patients have a lot of complications, as mentioned, retinopathy, nephropathy, end-stage renal disease, neuropathy, diabetic foot, or lower limb amputation. Our Ministry of Health implement with the combination with the MOH, Ministry of Health, implement a pilot in 5 primary clinics facilities in Rafah district from July 2013 to January 2014, implementing the package of essential non-communicable diseases. This collaboration supported by WHO, and our goal was training and workshop for doctors, nurses, and clerks, then on-job training for this project. Next. After finishing implementation in Rafah district, we expand the implementation for all districts and which finished by 2019 to all 5 districts in hope that we spread this protocol to the all primary health care clinics. Next. The current gap which faces us in Ministry of Health and Primary Health Care, especially that new updating of protocols for diabetes and hypertension, lack of updating quick guidelines for them, lack of integration between primary health care and hospitals. Actually, there is no support for research and studies in these 2 fields. Strategy policy to decrease risk factors or raise the public awareness. Also insufficient continuous training programs, lecturing for all medical staffs, inadequate training on lowering risk factors and better lifestyle. Need to have certified diabetes educators to deliver proper education for diabetic patients especially, which will increase awareness of disease risk and compliance. Actually, there is a clear deficiency in computers in most primary healthcare clinics. We actually have only 13 clinics who have full computerized. Absence of technical connection between primary healthcare and hospital as well. Shortage of minimal need for examination for diabetic and hypertension patients. For example, monofilament tuning for blood pressure measures, ophthalmoscope, ECG machine, or Doppler ultrasound. The lack of essential medicine is clear, and this shortage also in the new generations of anti-diabetic, for example, drugs, and new generations of antihypertensive drugs, as well the insulin pen. In MOH, we haven't insulin pens essential for type 1. I hope this deficiency will be overcome. About deficiency of diagnostic and laboratory services, deficiency in glucometers, glucose test strips, for example, ketone protein test strips, validated A1C and continuous supply, albumin creatinine ratio, electrolytes, and lipid profile, which is essential for monitoring and evaluating any diabetic or hypertensive patients. Infrastructure, we need to creation a national comprehensive diabetic center, creation of diabetic foot care, extend the computerized healthcare system. The first suggestion of projects is diabetic foot care center or centers. For example, to be center in Gaza Strip or 5 centers in the 5 districts, for example. If one center, the duration by 21 to 25, I think this will help all diabetic patients and hypertensive as well, because most of diabetic patients have hypertension. Project current indicators, if it is persist, the annual screening for diabetic foot neuropathy, retinopathy, nephropathy, and cardiovascular risk patients will undergo foot neurological and vascular assessment. Empower doctors' performance about managing diabetic patients, improving of psychosocial aspects, which is very important for this category, vulnerable group of people. Expected indicator determine as early as possible any risk factors for diabetic foot complications such as neuropathy and ischemia, reduction of amputation and ulceration with timely referrals. This is the estimated cost for simple center, for example, to be put in our centers, for example, 3 rooms, for example, I think it is $25,000. Project objectives to adopt and adapt the WHO PEN 2020 HEARTS protocols, to develop quick guidelines, perform training for medical staff, develop unified and computerized patient file, change essential drug list to the new generation of list, as I mentioned. Next. Next. The second, I think, the second project is the quick diabetic and hypertension guidelines to be finished by 21-22. It will help healthcare providers, doctors, nurses, and Ministry of Health in Gaza Strip. Current indicators update the national non-communicable disease strategy and guidelines, and expect indicators printing diabetic and hypertensive guidelines, training the majority of doctors and nurses, expected cost $5,000. The project objectives to update knowledge management, easy to use one language between primary healthcare and hospitals, suggest committee for scientific preparation guidelines, to revise national guidelines to validate and adapt them, perform training on the updated guidelines. Laboratories and medicine, we need to provide laboratory and materials to be sustainable and maintenance all the time, such as CBC and chemistry, providing the necessary medicines for 1 year at least, and this is the estimated cost. About summation of our projects is diabetic foot care center or centers, quick diabetic and hypertension guidelines, laboratory and medicine, which is very important. The total estimated cost is 5,679,183. Thank you. Thank you.
Thank you, Dr. Amal, for your presentation. In a summary, Dr. Amal presented that the Ministry of Health is serving around 25,000 cases with NCD, either diabetes or hypertension. And they have started a pilot of implementation of the PEN protocol in 2013. And now this implementation is completed in all districts by 2019. The major gaps, as mentioned by Dr. Amal, refer to one is the policies and the protocols, and about the updating of the protocols and the strategies, as well as the coordination between the primary health care as well as the secondary cares in the level of the hospitals. There is also she mentioned that we need to improve the researches, especially related to the diabetes and hypertension, and about the staff training, which was almost mentioned by all colleagues in all specialties. In addition to the equipment, she referred to the need to improve the infrastructure related to the computers and health management information system. In addition to the equipment required to provide a comprehensive service to the NCD patient, she referred to the monofilaments, to the glucometers and the strips. There is a gap in the medication, and as well as a gap in the lab supply, as well as the instruments needed, especially about the glucometers, the strips, and the testing for hemoglobin A1C and the renal function test, albumin creatinine ratio, in addition to the electrolytes and the lipid profile. She mentioned, she presented three proposals. One is for the diabetic care center, and to provide comprehensive services for the diabetic patients. The other one was for quick guidelines for diabetes and hypertension with the related training. And the third one was about ensuring and securing the lab supply and the medication supply for sustainability of the services to the diabetes and hypertension patient, with almost an estimated cost of 5,600,000. Thank you, Dr. Amal. Now we will go for the second participation about the cardiac health services that will be presented by Dr. Mohammed Habib. Dr. Mohammed Habib is a PhD holder. He's the consultant and interventional cardiologist, well-known name in Gaza. He is the head of cardiology department at Al-Shifa Medical Complex. We can see he's one of the founder of cardiology in Gaza. He is enjoying a long experience since 2006, and he's assistant professor at the Islamic University in Gaza. Dr. Mohammed Habib, please, you can start, and I would like, excuse me, to remind you that you have 10 minutes for your presentation. Please go on.
Okay. Good afternoon. Thank you very much for this nice presentation. Start?
Yes, please, go on.
Okay, we speak about cardiac services in Gaza Strip, about cardiology, cardiac catheterization, and cardiac surgery. Our committee, Dr. Hassan Al-Zammar, Dr. Mohammed Abu Nada, Dr. Mohammed Nassar, Dr. Amal Zabtout, Dr. Yusuf Al-Jesh, and Dr. Ahmed Zabtout. The current situation of cardiovascular or cardiology and cardiac surgery services in Gaza. We have 6 cardiac catheterization centers in Gaza, 2 cardiac catheterization centers in Ministry of Health, one of the European Gaza Hospital and another in Al-Shifa Hospital. And we have 4 cardiac catheterization centers in private and NGOs sectors. Cardiac surgery units or department, we have 5 cardiac surgery units, 2 of these in Ministry of Health, one of European Gaza Hospital, and this is closed because of COVID-19 pandemic and because of restriction cardiac surgery teams. Another in Al-Shifa Hospital, and only effective unit now is Al-Shifa Hospital. And we have 3 department or unit in private sector. All of these are ineffective because lack of cardiac surgery teams. We don't have any pediatric cardiac surgery until now in Gaza. Pediatric cardiology department, we have 2 pediatric cardiology departments, one of these in Abdulaziz Rantisi Hospital and another in European Gaza Hospital. Now the only hospital that perform both interventional, primary PCI, elective PCI, pacemaker, ICD, CRT implantation, and cardiac surgery in Al-Shifa Hospital. Medical staff in Gaza Strip, we have 49 cardiologists working in 5 hospitals, and from these, just 9 cardiologists can be interventional cardiologists and can be done diagnostic and therapeutic cardiac intervention. We have 5 cardiac surgeons and 5 pediatric cardiologists. The total number of diagnostic cardiac catheterization about 3,500 cases per year, and for PCI or percutaneous coronary intervention, about 3,200 procedures per year. So that we need about 4,000 coronary stents, 700 peripheral stents, 1,000 coronary and peripheral balloon, 200 pacemaker device, 50 CRT device, and 100 ICD device per year for patients in Gaza Strip. And all this procedure can be done in Ministry of Health hospital and in private hospital in Gaza Strip. The annual open cardiac surgery for adult patients, about 500 cases, 350 coronary artery bypass grafting, and another for valve surgery. And we need yearly about 350 cases for pediatric cardiac surgery, all of these transfer to West Bank and to outside hospital of Gaza, because we haven't any cardiac surgery centers for pediatric patients. And we need about 120 cases for pediatric cardiac catheterization. Policies protocols in Gaza, weak policies and plans aiming to developing heart services and cardiac surgery. We haven't any real control over private centers outside the governmental hospital in Gaza or in West Bank or in abroad. We didn't have any pediatric cardiac surgery, and we have a restriction number of adult cardiac surgery in Gaza. We need a lot of machines such as transesophageal echocardiography, and we need a new cardiac catheterization machine for Shifa Hospital. The most important problem in our department or our center, interruption of cardiac disposable or shortening of viability of cardiac disposable such as coronary stent, balloon, a pacemaker, ICD, CRTD. The first project name, disposable for cardiac surgery and cardiac catheterization. Now, Gaza Strip needs about 7,000 cases for diagnostic cardiac catheterization and therapeutic cardiac catheterization, and need 500 cases for adult cardiac surgery. We can make 150 cardiac surgery, and we make about 4,000 procedure for adult cardiac catheterization. And others must be transferred outside of Ministry of Health Hospital in Gaza Strip or in West Bank. This project need about $1,200,000. The aim of this project to provide disposable for cardiac catheterizations, such as cardiac surgery valves, coronary stent, coronary balloon, pacemaker, ICD, and CRTDs. The aim of this project to supporting all of this patient can be done for cardiac patient in Ministry of Health Hospital, and to reduce listing or to reduce the waiting list for cardiac catheterization in Ministry of Health Hospitals. Another project, cardiac surgery for pediatric patient. We have we need at least 4 doctors and nursing and all team for this project. And this project cost about $1 million. The third project, echocardiography and transesophageal echocardiography. At this moment, we haven't any transesophageal echocardiography in Gaza Strip. We need at least 2 transesophageal echocardiography machine. One of these for Nasser Hospital or European Gaza Hospital, and another must be in Shifa Hospital. This project cost about $200,000. The last project for cardiac disposable or cardiac surgery disposables for pediatric patient, we need about 120 cardiac catheterizations and 350 open heart surgery for congenital heart disease. And this project need about $1,300,000. The training or for pediatric cardiac surgery and adult cardiac surgery, we need at least 2 cardiac surgery and 2 pediatric cardiac surgery, and vascular surgery about 20 doctors in Gaza Strip. This project maybe need $500,000. The laboratories, medication, and the disposables, this need also about $500,000. The total project for education for pediatric cardiology doctors and adult cardiology doctor and for disposables such as coronary stent, balloons, peripheral stent, peripheral balloons, and devices for arrhythmia such as pacemaker, ICD, and CRTD. We need about $5 million total. Thank you very much.
Thank you very much, Dr. Mohammed Habib, for your concise and informative presentation. Actually, Dr. Mohammed Habib tried to cover all the aspects related to the facts about the cardiac health services in Gaza. He mentioned that we have 6 cardiac catheterization centers in Gaza, 2 related to the MOH, the other are private, in addition to 5 units for surgery, 1 is effectively working. We don't have here in Gaza a pediatric cardiac surgery, and we have 2 pediatric cardiac centers in whole Gaza. He mentioned that we have a lot of gaps, although we have seen here in Gaza a lot of improvement in the relation of related to the cardiac services here, but still there's a lot of gaps. These are related to the policies, and we need to have a control over the private sector, as mentioned by Dr. Mohammed. This need to improve the policies and strategies. There is a shortage related to the equipment, especially the transesophageal echocardiography, and he referred mainly to the shortage which we suffered for a long time related to the consumable. Accordingly, he suggested a lot of, and his team, some of the projects related to the gaps to overcome and to bridge these gaps. One is to provide the consumable related to the adult cardiac catheterization and cardiac surgeries with an estimated cost of $1,200,000. The other is related to the pediatric cardiac surgery consumables. He also suggested, he made a proposal with his team about the need to contract a pediatric surgery team. He suggested 5 teams to be contracted and working in Gaza. In addition to the need to support the cardiac specialty in Gaza with transesophageal echocardiography, he proposed to have 2 sets, one for Nasr and the other for Shifa Hospital. In addition to the need for capacity building of the staff and the training of the MOH staff, as well as the need to support the Ministry of Health with the lab and medication required to serve the cardiac patient. Thank you very much, Dr. Mohammed. Now we will go for the 3rd presentation that will be about renal health services. Our presenter is Dr. Mustafa Al-Aila. He is a well-known founder of the pediatric nephrologist. Dr. Mustafa is consultant pediatric nephrologist. He was the former ex-director of Rantisi Specialized Pediatric Hospital, and he was the former head of pediatric nephrology department at the same hospital. Dr. Mustafa is working since 1998 in the field of pediatric nephrology. So, Dr. Mustafa, you are welcome, and you may share your presentation and start your presentation. Thank you very much.
Thank you very much, Dr. Khalid, for your introduction to me. Introduce again. Today we'll talk about the kidney service needs for 21 to 22. I'm the head of this committee, and these are the names of my colleagues: Dr. Abdullah Pishawi, Dr. Razi Yazji, Dr. Riyad Barbakh, Mr. Hamid Mushtaha, Mr. Muhammad Shatat, Mr. Sahil Fleifel, Dr. Faiz Zida. The contents will comprise overview, current gaps, priorities, and summary. Today we'll talk about 3 topics. 2 of them new to our Gaza Strip, and the 3rd one is the shortage of essential medicines for renal patients. The first topic is manual continuous ambulatory peritoneal dialysis overview. As we know, end-stage renal disease in children are treated by renal replacement therapy through one of the following 3: either renal transplantation, hemodialysis, or peritoneal dialysis. In Gaza Strip, around 8 children every year need peritoneal dialysis and referred for this cause to Israeli hospitals. Every patient of them need frequent referrals, nearly 1 visit every month. to fulfill some needs of manual CAPD, like insertion of the peritoneal catheter, training of the parents, or to bring the consumables needed, or regular follow-up and evaluation, as well as the treatment of complications. We have current gaps of the presence of MCAPD, like the policies, procedures, and protocols. This service is not available really in Gaza at the moment, and the child who needs this service has to be referred to Israel. The problem is that the Israeli hospitals offering the automated peritoneal dialysis. Automated peritoneal dialysis depend on the use of peritoneal dialysis cycler. As we know, this will work with electric current. As electric current in Gaza, as we know, is a big problem. The substitute is manual CAPD. Manual CAPD technology really nowadays is developed as well as the automated peritoneal dialysis, and we can present it in Gaza. It can be started in Gaza to avoid the electrical current impact sequelae on the patients. We need, from the gaps also, we need training of one surgeon, one pediatric nephrologist, and 3 nurses. The surgeon is to learn how to insert laparoscopically the Tinkoff catheter. Regarding the equipment, we use manual methods, so no sophisticated equipment. Drugs and consumables. The drugs depend here on the use of peritoneal dialysate bags set of different dextrose concentrations. Consumables like Tinkoff catheter, twist extending catheters, disinfecting mini caps, disinfectants, and face masks, organizer for distribution of the fluid inflow, outflow, and cooling. Spraying scale to measure the amount of fluid used or outflow. Diagnostic and lab services, really most of them are available, but we have to develop the peritoneal outflow analysis and cultures to be including the aerobic and anaerobic and fungal culture and sensitivity. Regarding the infrastructure, it is manual process again. It is, and there was a past experience for this service in Gaza from 1999 to 2003. By myself, I worked that things at that time. Will help to facilitate this past experience will help to facilitate its application. Priorities. To summarize, the project name again is Manual CAPD, and the location will be started in Rantis Specialized Pediatric Hospital, because the children usually need it more than the adult, of course. Project duration, it can be started since this year, but to be continuous. Beneficiaries, the young infants, and because they have very difficult vascular access. Young infants who has end-stage renal disease, of course. And the children who suffer from end-stage renal disease and consumed all the vascular access and has no appropriate vascular access for hemodialysis. The indicators for the project, really, we still referring the patients who need CAPD. Expected indicators after implementation will depend on the international peritoneal dialysis adequacy tests like KTB and creatinine clearance. Expected cost for this project yearly around 157,000 yearly for the 8 children. After that, if the numbers increase, I think the cost will be decreased also. Project objectives: to prevent referring the patients to Israeli hospitals for CAPD, to save the patients from the burden of the very frequent troubles. Founding this necessary service, which is in many patients is the only choice and even maybe life-saving for a lot of them. The second topic is plasmapheresis. Again, we can do it in Gaza if the facilities are present. This service is not available in Gaza yet. Therapeutic plasma exchange is a blood purification technique designed for the removal of large molecular weight toxins. Plasma exchange can be, or plasmapheresis, I mean, can be performed either by traditional centrifugation method or membrane separation method, which is the new one. Membrane separation technology can be performed using existing classic or standard hemodialysis machine. This method can be done by hemodialysis team with a minimal additional training, on-job training. We need this service for around 10 adults and 5 children yearly. Number of sessions for each patient is 8 sessions. This method is nowadays commonly used in the United States and more popular in Germany and Japan. Regarding the policies, procedures, and protocols will be applied according to the international measures. Plasmapheresis is indicated in a lot of diseases. Something of them is renal and others are not renal, but it is life-saving for a lot of patients. Before renal transplantation, one of the indications, before renal transplantations for patients who need transplantation, but they have some diseases like focal segmental glomerulosclerosis. They have to use plasmapheresis to be treated by plasmapheresis before transplantation to avoid the graft rejection. Thrombotic thrombocytopenic purpura, and it is a lethal disease if not treated. Goodbasher syndrome, HELP syndrome, myasthenia gravis, Guillain-Barré, etc. Staff training is not a significant gap because skilled nephrologists and skilled dialysis nurses in Gaza can use the standard machine with a minimal on-job training. Equipment, as I said, hemodialysis machines are present, nurses, doctors are present. We need only plasma flux filters suitable for this plasmapheresis of adult size and children's size. The drugs and consumables needed for replacement of this plasma is the fresh frozen plasma and the human albumin bags. For each child, for each session, we need 6 bags of albumin. For the child, 3 bags of albumin each session. The grand total of, we need 120 filters yearly, human albumin bags 600 yearly. Regarding the lab, diagnostic lab, the traditional lab present is enough, except we need Adams 13 test, which is not available. And this is important for the diagnosis of thrombocytopenic purpura, thrombotic thrombocytopenic purpura. Regarding the infrastructure, there are no problem because we have the hemodialysis units and the skilled doctors and skilled nurses. To summarize, the project name is plasmapheresis, and we can use plasmapheresis as a location in Shifa Hospital, dialysis unit, Nasser Hospital, hemodialysis units, and as well as Rantisi Hospital's hemodialysis unit for children. Project duration, it can be started when the facilities are present and to be continued later on. Beneficiaries, 15 patients yearly, adults and children. Project current indicators. We're repairing the patients for plasmapheresis, and capability of doing renal transplantation for patients with certain diagnoses like focal segmental glomerulosclerosis till the moment. After implementation, the indicators will find it relief of the disease and signs, disease size and symptoms, limiting the need for referring the patients to Israel, minimizing the morbidity and mortality of those patients. Expected cost $775,000 yearly. Project objectives to find this service in Gaza and avoiding burden of patients' travel to save the time, which is important to participate in the earlier relief of the disease episode. Founding this necessary service in many patients is the only choice and even maybe life-saving. The third topic is the shortage of some services or some materials or drugs needed for the current services already offered to our patients, like hemodialysis in general and conservative treatment for the kidney disease patients, like laboratory CBC and chemistry and consumables with around estimated cost around 130,000. Medicines, providing the necessary medicines for 1 year. 3, I think the slide, this is not our slide. Sorry. Next. The slide is here. Okay. هي مع انه انا نطحت. اوكي مش مشكله. Providing okay. Others including UPS to hemodialysis center to the in Al-Aqsa Hospital, rehabilitation of dialysis department in Al-Shifa Hospital, providing retroscope for Nasser Medical Complex, equipping Hind Al-Dagma hemodialysis center in Khan Yunis, providing electricity generators for Noura Al-Ka'bi Center in the north. Also dialysis diploma training for 20 nurses. All most of them are not specified. To summarize, continuous ambulatory peritoneal dialysis cost yearly 157,000. Plasmapheresis 75,000 yearly. Laboratory and medicine consumables around 5,360,000. Others not specified yet. Estimated cost for the project number 1, 2, and 3, 5,600,000. Estimated cost for the project 4 not specified. Thank you, Madam.
Thank you very much, Dr. Mustafa. Actually, precise and up to the point presentation. Thank you very much. Dr. Mustafa summarized the requirements and the gaps in mainly 4 points. One is related to serving those people who need to be referred continuously to and travel or to occupied Palestinian territories at what we call Israel, and these people also need. He suggested a new technique so that it will mitigate the issue of electricity shortage in Gaza, as well as decrease the need to referral. That is the manual continuous peritoneal dialysis. And the other issue is the plasmapheresis. It is useful for both kidney patient and non-kidney patient, adult and pediatric. And the third issue was related to the lab supply, medicine, and consumable, and that's related to the serving renal patient with renal diseases. Thank you very much, Dr. Mustafa. And now for the discussion part, I would like to first request everybody that he may share his question through the chat or raise hand. And before opening the floor for all the participants, I would like to introduce Dr. Aed Yaghi for a small comment and during the discussion. Please, Dr. Aed. Dr. Aed. It seems that he is not joining. Dr. Aed Yaghi. Okay, we may go directly now for the opening the floor for the colleagues. If anyone is interested to raise any questions, and you are welcome. So I think there is no questions, no comments. By this way, I will conclude this sessions. I will thank everybody, Dr. Ahmed Zakout, Dr. Mohammed Habib, and Dr. Mustafa Al-Aila for their wonderful presentation, and informative one. Thank you very much, and hope the best for everybody.
Okay, thank you, Dr. Khalil, and thank you all the presenters. And now we are moving to the final session on mental health. This fifth and the last session of this conference will be led and managed by Dr. Usama Abdu, a psychotherapist and clinical psychologist, currently working as a mental health manager with MDM France. Dr. Usama has been working with many international organizations such as the UNRWA, Gaza Community Mental Health Program, MSF France, and IAH Turkish organization. So please, Dr. Usama, welcome and go ahead with this session. Organization. So please, Dr. Usama, welcome and go ahead with this session. Organization. So please, Dr. Usama, welcome and go ahead.
Thank you very much, Xenia, and special thanks to the Minister of Health, actually, for organizing this important event, which comes actually at an important and sensitive time. Good evening, everyone. Hope all has been having peace and calm day. Mental health and physical health are no longer separable. This is a fact. I believe that we may not be able to speak about complete healthcare system, healthcare services, without having the mental health services or the mental health needs of the healthcare service users addressed, assessed, and managed by different healthcare level staff. Within this frame of understanding, actually, we have been seeing serious attempts and serious efforts by the Ministry of Health here in Gaza regarding or towards better services, better healthcare services, including mental health, and we know for sure that the needs are huge. The needs are increasing, not only due to the fact or due to the natural increase in the population, but also due to the fact that the humanitarian crisis and the continuously deteriorating socioeconomic conditions are also pressing in this regard and distressing the already distressed healthcare system. Just to preserve all our time, because we have been delayed a bit due to technical issues, I would like to welcome here Dr. Abdullah Jamal. Dr. Abdullah Jamal is a very well-known board psychiatrist from Gaza. He's a great resource, actually, and he obtained the degree of the Arab Board in Psychiatry in 2014, and since that time, he had been working within the psychiatric services of the Ministry of Health, and he is also supervisor for the psychiatric training activities within the Ministry of Health. So please, Dr. Abdullah, I would like to have you on, and just a kind reminder that we will only have 10 minutes for your presentation. Please, Dr. Abdullah. Activities within the Ministry of Health. So please, Dr. Abdullah, I would like to have you on, and just a kind reminder that we will only have 10 minutes for your presentation. Please, Dr. Abdullah.
Thank you all, and thank you. Thank you all, and thank you, Mr. Osama, for this presentation. I'm glad to be with you this night. Good evening, everybody. I'm here to discuss the mental health service needs for 2021 and 2022. I hope I can present this presentation and to discuss it with you. First, there was a committee headed by Dr. Yahya Khadur, the Directorate of Mental Health Services at the Ministry of Health, and I was at this committee with Dr. Yasser Abu Jami and Dr. Muhammad Yaghi and other physicians to discuss these needs in the coming 2 years. Really, we have a special situation in mental health, because in the department of mental health in Gaza faces major challenges in the continuity of providing mental health services. Really, the recent aggression on Gaza increases the psychosocial suffering to our people. And really, we expected a lot of cases, especially PTSD cases, in the coming few weeks. Dr. Abdullah, really, children and women and elderly. دكتور عبد الله، إذا في يبدو إنه في عندك جهازين مفتوحين في نفس الوقت، يا ريت تسكر واحد منهم عشان ما يعملش صدى صوت.
لا، هو جهاز واحد عندي موجود فقط.
خلاص go on.
اوكي. لا، هو جهاز واحد فقط. اوكي. فطبعا children والwomen والelderly people هم في يعني considered among the most affected group or vulnerable group. We have another problem here, the psychotropic substances abuse and the problem of abuse at Gaza Strip. Really, we need to face this problem. At 2014, the National Committee for Psychotropic Substances Use was formed and was representative with several ministries headed by the Ministry of Health. And to deal with this substance abuse problem, the committee recommended the establishment of a treatment center for this problem. Really, we have a problem in the policies and the procedures. We need to train our staff, because here at Gaza Strip, we are about 2 million people. 2 million people, we have only one clinical psychiatrist at the Ministry of Health. So we face a shortage in the well-trained psychiatrists at the Ministry of Health, because we need a lot of psychiatrists really in this situation. And also it is not only staff training at the level of psychiatrists, but also at the level of clinical psychologists. We need a lot of clinical psychologists, because here at Gaza Strip, at the Ministry of Health, at least we don't have any clinical psychologist who is capable of doing psychological inventories in a good manner. So we have a problem in staff training. Also, we have a problem in the equipments for psychological inventories like IQ tests and personality tests like Wechsler and Minnesota multivisic personality inventories. We have a shortage and a huge shortage in the medications. We need really psychotropic medications. We prescribe a lot of medications to the patients. We have a huge number of patients that they need medications, but we have continuous shortage on these medications. Also, we have problem in the diagnostic lab services, especially the equipments needed for the examination of substance abuse like cannabis, benzodiazepines, and opiates. Also, we have a problem in the infrastructure. We need some treatment rooms like playrooms for the children and etc. We have other needs like community awareness and advertising services for substance abuse treatments. The first project that really we are in need for this project is the capacity building for psychiatrists. Really, we need to open, and we are now starting to develop a training program in psychiatry for our physicians, for our psychiatrists. We have to start this training program in the Arab Board of Psychiatry. So we need at least 1 or 2 psychiatrists from outside Gaza to join us, to help us in training these physicians here at Gaza Strip in the field of psychiatry, to have a good quality and quantity to continue our service needs and to improve our management plans to the patients. Another field is training programs to the psychologists, because we don't have really clinical psychologists here at the MOH. We need really to train our psychologists in this field of doing psychological inventories. Also, another field is we have to train our medical staff in the hospitals and the primary healthcare units, clinics, in dealing with patients with mental health. So we enforce to train our physicians in the primary healthcare units and the general hospitals in the MH gap, trying to help them how to pick mentally ill people, how to deal with these people, and how to treat minimal cases. Another situation is providing psychiatric medications. Really, we have a shortage in psychiatric medications in the quality. As we all know that our patients are vulnerable. Most of them have problems in the daily level of functioning. They can't afford to buy these medications. So we have to prescribe these medications, and we are trying to let these medications available for these patients. We have to do other projects like procedure manuals and policies. We have lack in standardization in the treatment protocols and policies, and we have to build our treatment protocols and policies to be to facilitate our jobs and to standardize the healthcare services at Gaza Strip. Another project is helping the helpers. As we know, after this war, frontline workers, medical staff, paramedics, civil defense, about 4,000 participants, they need help. They need us to help them to decrease the anxiety and depression level. So they need some psychological support to decrease their anxiety. Providing psychological inventories. We need to train our psychologists, and also we need to provide them the psychological inventories who they need to work on it. Another project that we need to establish a treatment center for the substance abuse patients, because these patients at Gaza Strip are about 20,000, but we don't have a really established treatment center for these patients. We need to have a closed service of treatment and rehabilitation center for the patients. So we have to build to establish a treatment center for these patients. And we have to provide, another project is providing free counseling and psychological support hotline that we need in these times and in the times of the war, of course. Also, we need, because we don't have except one psychiatrist and the Ministry of Health, we need also non-psychiatrists. We can build a training in the field of psychiatry, but also we need a highly specialized subspecialties in the psychiatry, like adolescent psychiatry, like forensic psychiatry, child psychiatry, emergency psychiatry. And if we can build a diploma in the psychiatry for the GPs, it will be very good. We have also to provide laboratory materials for the mental health and weaning, and providing the laboratory materials and for the lab. So we have many projects like capacity building for the psychiatrists, capacity building for the clinical psychologists, building for the mental staff, the medical staff, providing the psychotropic medications, and all of these projects are really we needed at this time. Thank you for listening, and I'm sorry for being late on you.
Thanks a lot, Dr. Abdullah. Really much needs. And huge needs actually, cross-cutting all the levels, all type of needs regarding mental health services. Just to conclude on what Dr. Abdullah Jamal has presented, he started by mentioning about the vulnerable categories of the population in Gaza, including children and women, who are being and continuing to be exposed. He also went through the different difficulties related to the psychotropic medications, including the shortages, including the unavailability, and also the misuse, which should be controlled in a way or another. In addition to that, he mentioned about the equipment, and he emphasized in more than one statement about the need to be having the psychometric tools, actually, to have psychological testing, which should be part, actually, of training and capacitating the Ministry of Health and the other mental health professionals, especially clinical psychologists, who should be capacitated and trained to use different inventories. Regarding also the different needs that Dr. Abdullah has mentioned, we need to be training we need to be having a psychiatric capacity building training, like board in psychiatry in Gaza, and we need to be having, in order to support this kind of capacity building program, 1 or 2 trained psychiatrists abroad coming and joining the Ministry of Health staff in order to make this possible and available. He also went through the needs also on primary healthcare level, and the need to integrate mental health on that level to be able to address mild to moderate mental health conditions through the MH-GAP approach. In addition to that, helping the helpers program is still a big need within the Ministry of Health, especially for the frontliners and the ones who are usually exposed, like ambulance drivers and emergency medical service staff and emergency department staff and all those who have been and still being deployed within emergencies. He also continued with the substance abuse or substance use treatment center, actually, and there is a huge need in the Ministry of Health to be having an adequate center, a well-equipped center to address the issue of addiction. I would also add my voice actually to Dr. Abdullah, and just to emphasize the need to start having a mental health act, actually, which should be organizing all acts and actions related to mental health within and outside the Ministry of Health. So thank you very much, Dr. Abdullah. I would like now to go for opening the floor for the discussion. Please, Dr. Abdullah, stay with us for in case there are questions that you may be interested to answer. I would actually be happy to have Dr. Yasser Abu Jami' with us. I'm not sure if I can find him here. Dr. Yasser, are you with us?
Yes, hello everyone.
Hi, Dr. Yasser Abu Jami' is the General Director of Gaza Mental Health Program, local NGO specialized in mental health in Gaza, great experience, extensive experience in mental health and human rights, and it's really a great opportunity having a comment from Dr. Yasser in this session. The floor is yours, Dr. Yasser.
Thank you very much, Usama. Thank you, Dr. Abdullah, and the organizers, the Ministry of Health. And let me begin by saying, you know, we are just getting out of a ceasefire after attacks that continued for 11 days, very brutal attacks that led to more than 200 people killed and more than 250, including children, women, etc., and more than or almost 2,000 people who were injured. We used to do research in GCMHP about what happens to the population after such brutality, and the usual finding is not far from what the international community findings or research studies, which is about 1/3 of the population affected or exposed will be really showing symptoms of PTSD and would need some sort of treatment. UNICEF about last week, they said that about 330,000 children are in some need for psychological care, or some kind of psychological care. Let's assume that only 10% of those 330,000 children will be in need for some psychiatric assessment. That's 30,000 children. By no means Gaza Strip is equipped to provide psychological and mental health intervention and to meet the needs that are on the ground. By no means that we can do that. However, we hope that at the same time there will be enough support to this very important sector. The request that came from Dr. Abdullah requesting, you know, some training programs and some like a couple of training centers. And actually the biggest request was $1 million for the psychotropic medications. And I'll tell you one thing, you know, I have seen most of the previous recommendations and previous presentations. Really, Dr. Abdullah, the requests from the Directorate of Mental Health are really modest. And I think you deserve to get all the support and all the funding that you have requested, looking at not only the humble requests, but also at the massive needs, you know. And we keep saying again, for the last very few years, that it's not only providing physical care that saves lives. In Gaza, providing mental health intervention also saves lives. In the last couple of weeks, we had an unfortunate issue when one or two actually young people committed suicide at the same day. In the last couple of days, also, we heard many reports of increase in domestic violence against women. A woman was killed 2 days ago by her husband. Now, these are all very troublesome signs for a place like Gaza Strip, which is known for its huge culture, huge respect for human rights, and huge love for the community. So this is just to say a request, you know, and the request comes just to support the funding requests that were made by the Ministry of Health Directorate of Mental Health. This sector is very marginalized, and I can prove you now why it's marginalized. First, after those 11 days of attacks, it was the last one on the agenda for today's meeting. Second, instead of 3 presenters, we have only 1 presenter. But Dr. Abdullah, you have done very well. You have done everything that is needed from you. We put ourselves, and I hope that everyone in the attendees will really give the needed attention, pay the needed attention, give the needed priority to this very marginalized sector. Thank you very much for giving me that chance, and may Allah help us all. Thank you.
Thanks a lot, Dr. Yasser. As usual, really putting some seeds in the head, eye-opening speeches. I hope that the Ministry of Health decision makers are listening to all these comments. I hope also funding agencies and different supporters for the Ministry of Health and for the mental health services are being supportive to these speeches and have been listening to those needs. I'm wondering also if we are having Dr. Murad Abed with us. Dr. Murad, I'm not sure if we can get a comment. Thank you very much, Dr. Murad is a mental health doctor working currently with MDM France, which is an international NGO having a strategic partnership regarding the integration of mental health within the structures of the Ministry of Health. So please, Dr. Murad.
Yes, thank you. Good evening, all. Thank you, all my colleagues, for giving me this opportunity to make 1 comment or 2, maybe. Thank you, Dr. Abdullah, for your very good presentation. You presented the holistic needs for the mental health gaps and needs regarding capacity building, regarding the lack of psychotropics, and all needs that the Minister of Health and even the General Mental Health Directorate needed. Actually, I have 1 comment or 1 point to discuss or to emphasize. It is about the importance and the effectiveness of integration of mental health services among the non-specialized health facilities like PHC and General Hospital. MDM France has a great role in supporting the Minister of Health since 3 years at this point exactly. If you see, Dr. Abdullah, that you listed a lot of projects, some of them may be short-term, some of them may be feasible and easily achieved, but some of the projects that the minister needed may be somehow difficult and need more times, need more specialized providers to be included to conduct. The most relevant and makes sense for me is the project number 3. It's regarding the MH gap, the international evidence and the international evidence-based tool that WHO created to integrate mental health among non-specialized service providers. MDM France started this role by supporting the Minister of Health by opening and creating the MH unit at Al-Aqsa Hospital. We succeeded to create the unit and support and capacitating the practitioner at the emergency department, especially with the mental health gap training, with appropriate and intensive at the first with technical supervision to facilitate early detection and management at the emergency department level, providing the psychotropics according to protocols and flowcharts that the MDM created in partnership with the ministry. And now we are in the process of supporting the integration of mental health services at the primary care level at the middle area. I can say at this point that we finishing or successing all the points. We are still in the first steps of supporting. We need a lot of support. Needs are growing faster than we are doing, and that's it. Thank you.
Thanks a lot, Dr. Murad, for your comment. I'm wondering if we will be having any questions regarding the presentation from Dr. Abdullah, or even the two comments that we had from our guests, Dr. Yasser Abu Jami' or Dr. Murad Abed. If no questions, no hands raised.
Really,
yes, Dr. Abdullah.
Really, Mr. Osama, thank you for asking about the Mental Health Act. Really now at the Ministry of Health, we started to build a new Mental Health Act for the new Palestinian Mental Health Act. We are looking, we have a look really on the Mental Health Act at Jordan and Kuwait and Qatar, and we are now in the process of making a Mental Health Act that is really very important to standardize our job.
Thanks, Dr. Abdullah. I think we are having another comment from Asia, MDM Spain. Please go ahead, Asia. Asia. I can see from my side that you are unmuted, Asia. I don't know from your laptop if you could unmute yourself, or what's the problem? I'm not sure.
Hello?
Yes.
Osama?
Yes, welcome.
Yeah, hi everybody.
Most welcome.
Thank you very much for your presentation and the presentation of Dr. Abdullah. I would like just to add a little thing about some intervention that I know by myself, that we were part of delivering such training and capacity building for the staff, mainly in the issue of child mental health. Regarding the inventories, I would like to say that we start having collaboration with some psychologists from abroad to deliver a specialized training on Wixler, on using WISC, and we deliver, we provide more than 6 to 7 batteries, 2 for Ministry of Education and 4 to Ministry of Health. So the participants were the psychologists from the community mental health centers and the counselor in the central counseling unit. So they benefit yet from previous training, and we are preparing to have a session of supervision to follow the work of the practitioner in the field. This is regarding the Wixler, regarding the match gap. I have always some comments about this training. We know, all of us, that we were a part of these big projects since years, but I think that we are in need to evaluate where we are with this match gap, because a lot of people are trained, but the effectiveness of this training inside our primary health care is non-seen. I don't think that because of the material or the non-skilled trainers or the bad attitude of personnel, but we have to think really about the cause of non-effectiveness of this training on giving more support, psychosocial support, to our beneficiaries inside the primary health care. Till now, we are asking for more capacity building for the doctors working in the primary health care, and we are in between detecting cases or managing the case, without considering the bad setting of the primary health care, the load that each doctor can see or the nurse can see in the primary health care, and non-preparedness of the setting of the primary health care. There is no safe place, no specialized place for people with mental health issues, or especially with children. So we have to think to evaluate all of us as NGOs, all of actors who are doing good things, تمام. But we have to evaluate our project, our intervention, our capacity building doing, تمام, to see what is the problem. So with MH gap, I think that we have all of us think how we should provide the MH gap, maybe in another way, تمام, to benefit from it, تمام. And regarding the issue of child mental health, as we know that there was a gap regarding the MH gap, that the module regarding the child mental health was not well elaborated. So all staff still asking for a child mental health training and capacity building on. Maybe some of you know that we support the 5 community mental health centers with a specialized playroom, تمام, for children. So the psychologists are able now to practice what they learn at least. So we have to combine what we provide as a training and changing the setting itself. Regarding the psychotropic, تمام, we still always demand for psychotropic, etc. But we have to think about capacity building of these staff. We know that the majority of doctors are general GP inside the community mental health center, psychiatric hospital, etc. So in parallel to providing the psychotropic, we have to think to provide more advanced training and specialized training on using psychotropic, especially for children and adolescents. So we have to combine these with that. So, and
I'm sorry, Asia, but they're directing me that we have only 1 minute for this comment. So please, if we could summarize or conclude on this point, which are really valid and good points to be taken into consideration for capacity building programs, especially for the integration. So please, we have 1 minute if you want to continue.
This was the last point regarding to combine what we provide as material with the training in need, not just to provide the psychotropic, but to add in parallel a specialized training on using the psychotropic, especially for children and adolescents. And in these regards, we are in our new project preparing to have a psychiatrist from abroad, specialized on mental health, to provide a psychotropic training for doctors in the psychiatric hospital and in the primary health care. And thank you very much for your session.
Thank you very much, Asia. Before closing the session, Dr. Abdullah, if you have any comment or reply, or shall we go back to Xenia for closing this session?
Thank you very much, Mr. Osama.
Thanks a lot. Hope everyone has enjoyed this session. And have a good evening all. Back to you, Xenia.
Thank you, Dr. Osama, and thank you to all the presenters and to all those who participated in this conference, and especially to all and everybody who had the patience and commitment to stay with us till the end. Now I am giving the floor to Dr. Abdulatif Al-Haj, Director General of International Cooperation Directorate in the Ministry of Health, for closing remarks and wrap up. Please, you are welcome.
سامعينك يا ابو المجد، مش على الفاضي، سامعينك اتكلم.
خلاص من عندي.
Assalamu alaikum. Could you hear me well?
تمام 100%.
I would like at the beginning to thank all of the partners who shared us with this actually a bit long conference, but it was actually needed, and the themes that we discussed in they are rich in lots of subjects that are very important, concentrating and highlighting on different important issues. Actually, I identified mainly that the main gaps that maybe all of the speakers concentrate and highlight on was on medications and consumables, on the equipments, on the capacity building, and of course on the standardizations of some of the services, of the critical services mainly, and of course the infrastructure. The projects that have been presented at the end of each presentation describes the parts and the components of those needs, of the gaps that we hope that our partners, the donors, the partners who will work with the donors to fill those gaps as much as they can, because with filling of those gaps, the Ministry of Health with the partners who provides the services in Gaza Strip, the NGOs, the UNRWA, will of course develop the health services. And when I speak about development of health services, I cannot be away from the relief. It's the same. In health we are relief or development, it's the same in the health provision in Gaza. We are speaking about a very crucial and important services, either in the physical or the mental, as Dr. Yasser Abu Jama said. We concentrate on the mental health and all the crises that we face, either the COVID or the Israeli aggressions and trauma are affecting strongly on the psychosocial status of our people. Hopefully we succeed in organizing this important. It is the first conference to be done by the Ministry of Health, and mainly to be done as a virtual conference, electronic. Lots of obstacles have been there. We passed over and we succeed to end our conference successfully with the efforts of all of our staff. Special thanks for the organizing committee, the persons our members who worked since early time this day and previously in preparing. Thanks a lot for the heads of the sessions that who were committed with us from the start. Also, thanks to the speakers who concentrate on the main gaps and describes the situation in the subjects that they present in the 5 themes that we covered as much as we can from the whole parts of our service in Gaza that is provided to our Gaza people. The numbers have been, they are very clear on the online, on the live online, and we hope that all of our partners, they could contact us by those lines, by the numbers, mentioned on the screen, and we are ready to cooperate with all of our partners, donors, all of the figures who shared us in that conference today, to provide them with all details that they want in regards to application and implementation of all of the projects that we present in the different 5 themes of this conference. Thanks a lot for all of our partners. Special thanks for our Deputy Minister, Dr. Yusuf Aburish, and maybe Dr. Yusuf wants to speak something at the end of our conference. Could you please, Dr. Yusuf, if you could hear me? Dr. Yusuf?
Yeah, Dr. Abdul Latif, actually nothing to add apart just to thank you all for attending and for organizing, for participation, for having these valuable comments. Actually, nothing to say about. Kindly accept my high appreciation and esteemed respect. Thank you all.
Well, thank you very much, and we will keep in contact, as I mentioned, along the coming days and months to guarantee the fulfillment of the subjects and the aim of our conference. Thank you very much all.
Thank you very much, and all the best to everybody.